helps with automatic, like heart rate, blood pressure. These sort of things can be affected when a patient stands up. They can get dizzy, they can fall down, they can have loss of bowel and bladder control. So the thinking problems also are troublesome, and they can be kind of like Alzheimer's disease. There can be confusion. I mentioned attention problems, but also trouble relating to things in space, so-called visual spatial problems, and memory loss. There can be trouble with sleep. People can act out in their sleep. They can kick and yell. Episodes of attention, and really the effects of the condition can vary. So people seem to be pretty good one day and other days not, and they're sleepy and disengaged and don't do a whole lot. Of course, this can also be a sign of depression. People can become depressed because they're sick. They can become apathetic. So all of it is a difficult situation for all of us, and we need to make things better. I was very moved by a piece that a doctor from Mayo Clinic, who I've met and had dinner with when I lectured there, named Daniel Drubach, wrote about his experience with Lewy body disease. He's a physician, and as physicians, we're used to hearing things like, heal thyself. Well, this is something that's tough to heal, but you have to cope with it. So he wrote a paper in one of our neurological journals. It's called Twilight and Me, a Soliloquy. So this is a very smart man who actually diagnosed his own illness, which was onset about age 60. And I just want to quote you a few things from it, because I reread it and I found it very moving and poignant. He said, I diagnosed myself with DLB, that's dementia with Lewy bodies, at approximately age 60. Almost immediately after I accepted the news, I decided to give my disease a unique name. I learned early on that the manifestations of the disorder were unique in every individual. And thus I wanted to communicate with my disease in a personal fashion. So I named it Twilight, perhaps because I realized I am reaching the twilight of my life. He goes on to talk about things like hope and fear. He said that after his diagnosis, he was very hopeful, but also very afraid of what would happen. And he felt as if there was a sharp sword resting on his neck, but even so, that he would never give up. And that's something that he quoted from the Talmud. He's a religious practitioner of Judaism. He talks about his illness, the presence. He says, the first symptom that I experienced was what I learned to consider a sense of presence, the strange sensation that someone was close to me or walking by my side, at times leaning against me. That's even when there was no one there. He said, the presence became an integral part of the strange world that I was entering. In addition to having the presence walking by my side, I also developed the sensation that somebody was missing from my house. While there are 3 of us in my family, I felt there should be 4. I do not know who the 4th person represented. He also talked about some of these phenomena that I mentioned. One of them was the visual phenomena. He said, I do experience visual sensations. He said, on my daily walk to a beautiful park, I practice accessing it frequently. I see a tree in all of its majesty. I'll concentrate on that vision, and then I see a prophet-like figure holding his arms up as if reaching the sky. And if I focus on the prophet, I see a flamenco dancer with her hands moving to the wind, and so on, I presume, to eternity. And then I mentioned hallucinations. He said, then there are the hallucinations. The first I remember having was while I was discussing a patient with a colleague. Suddenly, I saw a ballerina dancing in the middle of the room. And remember, this is a guy who's a physician who usually would know better, right? He said he saw hordes of furry animals traveling in his bedroom or invading his bedroom. He saw a tall man wearing a turban and a long gray cape, a baby who playfully crawled under the bed, forcing me to go after him again and again, and butterflies who caressed my face when I went to sleep. And he said it reminded him of that license plate that everybody sees once in a while that says, Don't tailgate, I break for hallucinations. He said, but months later, the hallucinations underwent a prominent change, which I think speaks to the evolving nature of the condition that people have. He said, it became difficult to tell whether their content was real or not, which of course is a problem. With time, more of them appeared to be real and therefore more frightful. He talked about dreams, very vivid dreams. He said that DLB allows me to simultaneously be a participant and an observer of my dreams. For instance, if I dream about a physical altercation between two individuals, I tend to be one of them, physically acting out on the fighter's side. You can see how people can be restless at night. And then he talks about his condition, saying, twilight has also blessed me with lucid dreaming. In normal dreaming, we're not aware that we're dreaming, but can recall the dreams after waking. In lucid dreaming, the subject is aware that they are in a dream scene and not in the real world in that dissociated state. So I think he's saying that he's more engaged in his dreams than what would otherwise be possible if he didn't have this condition. And then there were auditory hallucinations. He hears the sound of a washing machine in the basement, a real washing machine, and it sounds like a rock band playing. He said that he often hears his name called out at times in the voice of a young woman, a beautiful and soothing call. But of course, there's nobody there. At other times, he hears what sounds like a Gregorian chant. Of course, there are no monks around. And then he talks about his losses in mirrors. He says that he has an unusual relationship with mirrors. At one time in a restaurant, he left a table for a few minutes. When he tried to make it back, he felt trapped in all of the mirrors, and he was very panicked and needed a friend to rescue him. So these are the kind of experiences that probably you've heard about, and Dr. Drubach has written about articulately. He said that he has had losses, that in his career, he's a writer and he's a thinker, and he's had more trouble typing, he's had more trouble finding words. He's an amateur musician and he's had more trouble playing the guitar. He said his neurological status, including his thinking, that is his cognition, his hallucinations, his ability to play and write the guitar, like I said, can fluctuate from week to week, where sometimes he feels as light as a feather and other times he feels like he can't go on. And then he laments that life is contained in memories and he's lost a lot of memories. So he feels that he's lost much, that he's lost a lot of himself. So at this point, he writes that a few weeks earlier to writing this, that he had a confrontation with his condition. And he realized that he was reaching the end of his journey. And that he quoted Martin Buber and Pablo Neruda, the Chilean writer, that someday, somewhere, anywhere, unfailingly, you'll find yourself, and that only that can be the happiest and bitterest hour of your life. So he's coming to terms with his condition, and he's happy that he's come to terms with it, but bitter at his losses and sorrowful. I want to conclude and say that he asks, what's the end of this soliloquy? And he quotes a Hasidic master of the 18th century, that a person walks in life on a very narrow bridge. And the most important thing is not to be afraid. So I'm very moved by this piece, and I suspect you may want to look it up afterward and read it yourselves. And I think what we find in our patients and their families and caregivers is bravery, resolve, a wish to move on, the recognition that we need better understandings of the mechanisms of dementia with Lewy body disease. We need to work hard to do the research to find the mechanisms that will be responsive to treatments, to get better care and cures, and we need to make these accessible to everybody. So I think we look forward to a wonderful conference today. I mentioned that the room is full. I also want to mention there are a lot of people online. Hello, everybody online. Welcome. I think this is going to be a wonderful conference. Dan, I don't know if you want to introduce everybody, or I can. Why don't I let you go over the excellent program? And I want to thank Julie and the team for arranging things. This is a lot of work. Not easy to put something special like this together. And thank you. It's a privilege to be here with you.
Welcome, everybody. I'm glad everyone's here. My role today is to give you kind of an introduction so we're all on the same page of terminology, understanding kind of what we think some of the mechanisms are that causes the symptoms in Lewy body dementia. We'll talk about sort of the different subtypes, and then we'll talk about some of the treatments with the idea that at least to realize there are effective treatments for Lewy body dementias. So I think you all have the agenda and it's a full day, but so I think everyone knows I'm Dr. Dan Merman, a neurologist, behavioral neurologist at the University of Nebraska Medical Center, and kind of co-directing this Lewy body initiative with Julie Pavelka. And so I just want to kind of start off with this introduction. So one of the big questions is sort of why are we all gathered today? And there's two big reasons that we need to kind of have educational conferences about Lewy body dementia. One is it's very under-recognized. I think people don't understand some of the telltale signs we just heard about from Dr. Rizzo and aren't aware it's a unique cause of dementia. It has very unique manifestations and treatments. And so a lot of times there's a delay in getting a diagnosis. Sometimes patients are put on the wrong medicines or not put on medicines that could be helpful. And the other thing is helping someone with a Lewy body dementia is a challenging proposition, but there are a lot of treatments that can help symptoms. We don't have a cure, but we have a lot of effective treatments that can help many of the symptoms. But we have to kind of educate providers and caregivers of what the symptoms are related to, what kind of treatments there might be, what things to avoid, and so forth. So those would be some of the main goals, just to raise awareness of what is Lewy body dementia, how is it different from other dementias, and then to be aware that there really are effective treatments that can help patients. So these are the first list of questions I want to start with to think through. So a common one is, what is dementia? What's the difference between dementia and dementia with Lewy bodies and so forth? Then there's a whole question, what is a Lewy body? And kind of how does it relate to the symptoms we're seeing? Where does the name come from? And we'll talk about that. And then a little bit of how common is this and how's it related to aging and are there differences between men and women? So dementia is just a syndrome that implies that someone developed trouble with thinking that's severe enough to impact their everyday abilities. That's all dementia is. It's usually persistent. It doesn't usually go away, but it doesn't have to be progressive. So you can have a severe head injury, develop thinking problems, have trouble with day-to-day activities, but it might just stay the same. But typically, many of the dementias are progressive. They get worse over time. So when we think about Lewy body dementias, Alzheimer's, and so forth, it usually is progressive. And we'll talk later about this phenomenon called delirium, where suddenly people are confused when they're hospitalized. And that isn't the same as dementia. It can be related and more common in people with dementia. But so we want to kind of make sure that when we're evaluating people, this is a more persistent change in thinking that's not just this sudden confusional episode in the hospital. So if you took 100 people in a memory disorders clinic of older adults, this would be a common breakdown of the different causes. So Alzheimer's disease, or at least Alzheimer's changes, would account for about 60%. Vascular changes and vascular dementia can be an important subcomponent. And then the Lewy body dementias are another common cause of dementia. When you look at people older than age 80, one or more of these, so 2 or more at a time, is more common than just a single disease entity. So it's common to have both Alzheimer's changes in the brain and Lewy body changes, Alzheimer's and vascular changes, or all three. So we're kind of understanding the mixed dementias are actually more and more common as you get older. So it may not just be one change in the brain that produces symptoms. So I think this is a useful way to think about dementia. Dementia is just an umbrella term that encompasses all the specific subtypes. So dementia is the syndrome, but so you have dementia, but then what's the cause? And so that's what we often try to do in the clinic. Is it Alzheimer's disease? Is it a Lewy body dementia? Is it vascular dementia? Is it a combination? So this is kind of the umbrella concept. The same umbrella term can be used for the Lewy body dementias. When we use that terminology, Lewy body dementia, that's an umbrella term that is over the two subtypes. So there's two main subtypes of Lewy body dementia. So one is a subtype where patients have classic Parkinson's disease, often for many years, and later develop dementia symptoms. And that's called Parkinson's disease with dementia, or PDD. And the other one is patients that develop both the thinking problems, movement problems, psychiatric symptoms all at about the same time, or the dementias first, followed by the movement problems. That's dementia with Lewy bodies, or DLB. And they have this 1-year rule. So if the movement problems are by themselves for more than a year, then we're going to call it PDD. Or if the dementia is first, or the movement things are in about the first year, then we call it. Another way to kind of think of it, so there's two clinical syndromes where you could start on the left-hand side of having the dementia with Lewy bodies, so you have both thinking and movement problems at the same time, psychiatric symptoms, or you might show up in a neurologist office or a movement disorder clinic and be diagnosed with Parkinson's disease, and over time, often 5 to 10 years later, develop features of a Lewy body dementia. The interesting thing, when you get to the right-hand part of this slide, they're hard to distinguish if you look at the brain or if you look at the type of symptoms. So there's a lot of overlap, and that's sort of how we use the term Lewy body dementia. That in the end, they look very similar, just two different ways to get to that end stage. And I put the 30 to 80%. So, it's very common for people to start off with Parkinson's disease and later develop the Parkinson's with dementia, and different estimates, but probably closer to the 75 to 80% over time. So where does this Lewy body name come from? Who's Lewy? So Fritz Lewy was a physician and neuropathologist who described changes in the brain of somebody with Parkinson's disease in 1912. And these changes were in the brainstem and part of the circuits that are used, or that the brain uses to kind of coordinate movement. So the substantia nigra was the structure. These inclusions in the nerve cells were given his name, Lewy bodies. I'll show you some pictures of those. And later we found out, similar to what Dr. Rizzo was mentioning, it was an aggregation of an abnormal form of a protein called alpha-synuclein. So that's kind of what makes up the Lewy body. When it comes to cortical Lewy bodies, we really didn't have an appreciation for them for many years. So in the 60s, there were some descriptions, and it wasn't really until the 80s that we put two and two together, that some structures that are made up of the same protein, alpha-synuclein, but look a little bit different, that are in the thinking part of the brain or the emotional part of the brain. Those are kind of the changes that correlate with dementia, with the hallucinations and psychiatric symptoms. So those are cortical Lewy bodies in the thinking part of the brain, or the cortex. So this is kind of a picture of the classic Lewy body. It has kind of a halo around it. This is a neuron that's pigmented, that uses dopamine to communicate in the substantia nigra. These kind of changes would produce the motor symptoms of Parkinson's disease when they're affecting the motor systems, so the tremors and stiffness and slowness. And then this is a picture of the cortical Lewy bodies. They don't have the nice halo. They're harder to identify, but it was later when we could kind of stain or use immunohistochemistry to kind of see the alpha-synuclein protein, we realized they're really kind of made up the same thing. They just look different, but this would correlate with thinking problems, psychiatric symptoms. So there's a link between which parts of the brain are involved and our symptoms. So the structures that involved affect the function of the brain. And so these deep structures here are called the basal ganglia. It's hard to see, but it's kind of deep in the brain, and they work as a circuit to coordinate our movements. So when you start to get Lewy bodies in the basal ganglia, the movement coordination part of the brain, that's when we get breakdown of coordination. We might get tremors, stiffness, and slowness. So these are where Lewy bodies would produce Parkinson's disease symptoms or Parkinsonism, the Parkinson-like features. When the Lewy bodies on the right-hand side move into the thinking part of the brain, different lobes and parts of the brain are involved in different aspects of thinking, but it can involve memory, it can involve processing visual information, it can involve language, it can involve decision making. When the Lewy bodies move to those part of the brains, then we get the dementia symptoms. On the lower right are some circuits that are important for emotional regulation. And again, when Lewy bodies get involved here, we can get depression, anxiety, and can contribute to hallucinations with the cortical Lewy body. On the left-hand side are actual autopsy pictures of someone who had Lewy body dementia, and it's a staining type picture. So these are different stages of Lewy body dementia. The darkness are areas where there's a lot of Lewy bodies. So at the very upper left would be really no cortical Lewy bodies. This stage 4 shows some in the movement parts of the brain and beginning to get involved cortical areas. But this one over here, so on your left side, this lower right one here, has all these areas that are abnormal. These are all cortical Lewy bodies as well as basal ganglia Lewy bodies that would have all the symptoms we'll talk about today, the dementia, the psychiatric symptoms, the motor symptoms. So this is kind of the connection between where the Lewy bodies occur and the symptoms that we see. This last slide is just to say life is complicated and we're still trying to understand this relationship. About close to half the time, patients with cortical Lewy bodies and Lewy body dementia syndrome also have Alzheimer's disease changes. Sometimes it's mostly just the plaques, that's more common, but also some patients in the here, like 15% would have both amyloid plaques and neurofibrillary tangles enough to be diagnosed with Alzheimer's disease and the Lewy body dementia. So the co-occurrence is common, and there probably are subgroups of patients that do or don't have Alzheimer's change. But we kind of realize that we need to kind of find ways to prevent the development and spread of Lewy bodies. That would help many of the symptoms we'll talk about today. But we also have to be mindful that we may have to also target the Alzheimer's changes in the brain to really improve symptoms, because some people have both. All right. So how common is Lewy body dementia? So as Dr. Rizzo said, it's the second most common degenerative dementia. Alzheimer's number 1, Lewy body dementias are number 2. So it's quite common. We don't have good estimates to really know how many people in the US have Lewy body dementia, or certainly not in Nebraska. But a rough guess is about 1.5 million people in the US, probably about 4,500 in Nebraska, but that's a very rough guess of how many people, and many are undiagnosed. Lewy body dementia is an age-associated degenerative disease. It gets more common with age, often after age 50, typically after age 50, but gets increasingly more common with age. And it tends to be more common in men than women, which is kind of the opposite of Alzheimer's, where it's more common in women than men. So almost 2 times more common in men than women. And these are just pictures. Incidence means new cases. So they're looking at a group of people that don't have a Lewy body dementia, and then over time, as the graph rises, these would be cases. So this would be median syndrome of dementia with Lewy bodies. This would be Parkinson's disease with dementia. Each of them get more common with age, and you see the separation of men and women. And this bottom graph is just combining those 2 groups. And so as a whole, it replicates this idea that it's increasingly more common with age, certainly most commonly around age 70, 75 for the onset of symptoms, and more common in men than women. All right, let's change gears a little bit. We'll sort of talk about some of the symptoms. Question? Yeah. Thank you for telling me. I'll try to stand in front of this microphone. All right, thank you. And I can put on a mic here. So let me try to stay closer to this mic. Can you hear me okay now? All right. Thank you. Yeah, I could. Yeah. the how's this one work? All right. So for people that missed the first half of my talk, we'll go back. Yikes. All right. So this was the whole talk about these Lewy bodies named after this guy, Fritz Lewy. And there's two types. There's some in the movement part of the brain, the basic ganglia. This is the picture there. And then there's these types that involve the thinking part of the brain called the cortex. And they look a little different, but if you kind of stain them for this alpha-synuclein, they're made up of the same proteins. And these kind of correlate with the dementia symptoms. These are kind of the brain regions involved in movements. When the Lewy bodies are there, we get Parkinson's features. And then these are the brain regions involved in thinking and regulated emotions. When they get involved, we get the psychiatric and cognitive symptoms. And then up to 47% of people that have a Lewy body dementia diagnosis also have some Alzheimer's change, and probably 15% really have a lot of Alzheimer's changes. So we don't quite understand that, but that'll be, as we find new treatments, we'll have to be aware that both Lewy bodies are very important for all the symptoms we talk about today, but there also may be Alzheimer's changes affecting symptoms. Lewy body is the second most common cause of dementia. Alzheimer's is first, Lewy body is second. It gets more common with age, older age, usually starting around age 60, but in many cases, people start to get symptoms in their 70s. And it's more common in men than women. We don't understand that, but so then when we get to symptoms, realize that there's a whole variety of symptoms. That's what's one thing that's unique about Lewy body dementia is how many symptoms come together to produce, well, that we have to kind of cope with. So there are thinking problems, cognitive symptoms. There are motor problems. This is the Parkinson's features, and those are really at the core. Psychiatric symptoms are very common. And then we also see sleep problems and autonomic nervous system problems. So all these come together, and then we'll try to help patients with and try to manage. So when it comes to thinking, one of the hallmarks is slowing down of the speed of thinking, like how fast you can think. Commonly, patients know the answer, just takes a while to retrieve the information and to respond. There's a slowness of thinking. There's trouble with what we call executive cognitive function. That's decision-making, multitasking. And an example would be losing your train of thought in mid-sentence, things like that. There's memory problems, but it's a little bit different than Alzheimer's. It's a big problem with retrieving information you know, but you can learn new things. So in Alzheimer's disease, new learning is one of the biggest issues, like learning how to use a TV remote or some new information. But in Lewy body dementia, patients are better able to learn things, but they may not be able to tell you and retrieve that information when they're put on the spot, like on our memory tests. There's a lot of trouble with visual spatial processing. So the eyes are okay, but processing visual information is impaired, and that shows up in your everyday activities. And then one of the hallmarks of the Lewy body dementia is this fluctuation. Commonly, certain time of day is better. So the most common syndrome would be sundowning, so sharper in the morning, more confused in the evening, or maybe day to day, where one day amazingly sharp, the next day quite confused. So up and down is kind of a characteristic and a hallmark. And patients are very susceptible to this phenomenon called delirium, where there can be a sudden level of worsening and confusion, usually in the setting of a medical illness or hospitalization or surgery. These are just pictures of kind of those concepts. So there's this slow thinking, can't retrieve information, hard to make decisions, trouble drawing our clock and putting the hands on the clock, say 10 past 11, because just processing that visual spatial information is impaired. And then this up and down course is kind of the rule and not the exception. The motor symptoms of both Parkinson's disease and what we see in dementia with Lewy body are here. So we see slow movements, bradykinesia. We see stiffness, and that's something we often can feel on the exam, but you would notice when you're helping someone dress or things like that. There can be tremors. The classic Parkinson's disease tremor is just a tremor at rest when you're not doing anything, but it's not uncommon to have some tremors with movement and posture also. And then there often is a loss of balance, this postural stability that can lead to falls. So that's very much a part of the Lewy bodies and the movement part of the brain, kind of the core features of of Parkinson's disease and Parkinsonism. From your standpoint, you'd notice things like a loved one's voice is much quieter, handwriting is much smaller, they have a stooped posture, they take shorter steps, their balance is not very good. That's all kind of manifestations of these things. It's not uncommon to lose expression in your face. Looks like you're depressed and things like that, but you just don't have the normal expression. Later, trouble handling secretions and drooling would be common. This is kind of a caricature of these findings, but there is kind of a characteristic posture and walk that across the room you could say that person looks like they have Parkinson's features. The stoop posture, kind of the bent arms and bent knees. Many patients shake when they walk. The size of the steps, the stride length is decreased, are all things that you might see. Decreased expression in the face are kind of manifestations of the motor symptoms. So there's definitely thinking problems. There's motor symptoms, which is Parkinsonism. And the other symptoms are listed here. So again, psychiatric symptoms are very common. So depression, anxiety, hallucinations would all be very common phenomena. And hallucinations can be very early, especially in dementia with Lewy bodies. And we heard about that with Dr. Rizzo's summary of Dr. Drubeck's description of all the changes that he was experiencing. There are those interesting delusions where you think that someone's near you, the presence delusions. Another disturbing delusion is a misidentification delusion where you may not recognize your home as your home or your spouse as your spouse. And it can be transient, but it can be very, disturbing for caregivers when their loved one doesn't recognize who they are. In the setting of Parkinson's disease, on patients that are on medications trying to help their movements, we sometimes get impulse control problems from the medicines that are increasing dopamine to help with movements. And they can be pathologic gambling, kind of just difficult hypersexual kind of drive in this setting of controlling your impulses. The other symptoms that are important to be aware of, so sleep disturbance is really common in the Lewy body dementias. And there's a couple of precursors. So some people have restless leg syndrome, where they feel their legs feel uncomfortable. It feels like they have to get up and move before they're trying to settle down for bed. Or after they've fallen asleep, they're constantly kicking, called periodic limb movements of sleep. And those can be a precursor to Lewy body diseases, which includes Parkinson's disease, Lewy body dementia, and something called multiple system atrophy. And then this other phenomenon can be quite dramatic, where people literally act out their dreams. So they're asleep, but they may yell out, they may punch, they may kick. And if you wake them up, they can explain, well, I was fighting with this person. It kind of matches what they're dreaming. So those are all very common. And the REM sleep behavior disorder, acting out of dreams, is an important kind of specific marker for a Lewy body syndrome. Loss of sense of smell is really common. It's a little bit tricky now with COVID because that's another reason you might lose your sense of smell or head injury, but just having a Parkinsonian syndrome or Parkinson's disease or a Lewy body dementia, it's quite common to lose sense of smell. It may be manifested as things just don't taste right and they don't have as much flavor, which is much of our sense of taste is from what we smell. And then the autonomic nervous system, kind of this automatic nervous system that controls our blood pressure, our sweating, our bowels, our bladder, that system can be involved. And so two very common things would be constipation, which may be a very early symptom before there's a lot of other things and can be very difficult. And then the other is this phenomenon where you stand up and your blood pressure drops. Normally that autonomic nervous system would compensate. Your heart rate would go faster. You would clamp down on your vessels to kind of get more blood back to the heart. But when that system fails, then lightheaded or you can faint, and that can precipitate a fall. So these are all part of the Lewy body phenomenon. So in my last little section, I kind of want to switch gears. We kind of talked about some of the basics of what's dementia with Lewy bodies, and then what is a Lewy body, how the involvement of the brain correlates to symptoms. We've talked about some of the core symptoms of the Lewy body dementia. Now let's talk about treatment just a little bit. So we really do have some treatments for a majority of the symptoms. And we've talked about thinking problems, the Parkinsonism, psychiatric symptoms, the sleep disorder, and the autonomic problems. And And so we have a lot of decisions. We don't have a cure for the Lewy body dementia. And you'll find that, as I kind of this next section try to explain, it's a balancing act. We have medicines that can improve symptoms. They certainly don't cure them. And they often come with some side effects that we have to balance the benefit we're trying to achieve and not making things worse on the side effect side. So this is the part where sort of the art of medicine and some experience with all of the options and with the patient can lead to kind of better outcomes if you've got experience and knowledge about the options. So one of the principles of trying to treat someone with a Lewy body dementia is the same principles we use in geriatrics for older adults. It's to try to have a conversation with the patient and the family, try to rank order what's the biggest issue, what is impacting your quality of life the most, and what do we want to try to accomplish and target. Any kind of medication therapy, we have to do one at a time because we have to kind of see, well, what kind of side effects are we going to be dealing with that treatment, because they all have side effects. And then true in geriatrics and certainly in Lewy body dementia, you would use in a very low dose of these medicines because it's very common to get side effects from the medicine. And then kind of educating the patient, the family, saying, okay, this might get better, but this might get worse. So, help me kind of find the right level of this medicine to make you better. So when it comes to memory and thinking, there's an important brain chemical called acetylcholine. So in the brain, the nerve cells have an electrical signal, and between the two nerve cells, they release a chemical, a neurotransmitter, and that triggers the next nerve to pass on the electrical impulse. So there's sort of this electrical chemical communication. So many of our drugs target these chemicals, neurotransmitters, that can help a set of symptoms. So when it comes to memory, so attention, focus, memory, this chemical, acetylcholine, is very important, that neurotransmitter. So they have a funny name as a class. They're called cholinesterase inhibitors. These drugs kind of block an enzyme that would normally break down acetylcholine. So it's allowing more acetylcholine to be between the two nerve cells to help them communicate. So their names are listed, and they're ones that you know about. So there's 3 to choose from. I wrote kind of the generic name and the brand names. So rivastigmine, galantamine, donepezil are kind of the generic names. And it looks like they're all quite similar and can be helpful when it comes to thinking. So in somebody with a Lewy body dementia, they can kind of help with memory and attention. They can help with some of the psychiatric symptoms. They don't make them worse, so including delusions and even hallucinations. But they do have side effects. So this group of medicines can make tremors a little bit worse in some patients. And then they all share this property that they can give you some nausea or lack of appetite, loose stools or diarrhea, runny nose are all really common. So trying to figure out how much can I put up with that runny nose, or certainly with the diarrhea, that can be problematic. Sometimes we'll switch amongst these because one might have a little more problem with diarrhea than another. These medicines sometimes cause vivid dreams, not necessarily nightmares, but vivid dreams. So that's something we have to be careful with. Now, this is the first example, kind of the opposite. So more acetylcholine is good when it comes to attention and memory. There's many drugs out there that block acetylcholine, so we call them anticholinergic. And there's some that are just over the counter. So one would be that the common sleep aids often share this property. So Tylenol PM, just to pick on one, has Benadryl. And so diphenhydramine is kind of the chemical, but it's often used in some of the sleep aids. That's kind of working against you. It's going to make it more likely to have trouble with attention, memory, and cause confusion. So we try to get patients not to take that, but there are many medicines that are used in geriatrics that have anticholinergic properties. So it's smart to kind of be aware and to monitor that as a provider, that we're not actually adding medicines, or you're not on medicines actually making things worse. The other balance is with dopamine. So another brain chemical that helps, definitely helps in the movement circuits. So those basal ganglia circuits help. And so increasing dopamine helps with movement. So it decreases tremors, stiffness, and slowness, the hallmarks of Parkinson's disease and Parkinsonism. So those medicines are good. They're helping people move. But there are different pathways that use dopamine that can exacerbate the hallucinations and delusions. So they can make things worse. So that's the balancing act. So essentially all of our medicines used for Parkinson's disease symptoms or Parkinsonism increase dopamine, and almost all of our medicines used to kind of treat hallucination delusions block dopamine. So that's the balancing act that we have to kind of be aware of and try to kind of walk that tightrope. So when it comes to somebody who's really having problematic hallucinations, one approach is let's find the lowest amount of the Parkinson's medicines that will help the patient walk safely and not fall. The tremors are bearable, but not make the hallucinations worse. So usually some adjustments in the medicine or them on the movement side are needed. We think that the drugs that increase acetylcholine, the cholinesterase inhibitors, they're good. So keeping someone on that or adding that if they're not on it would be an important step. And then we have a dilemma. So if they're really causing a big decrease in quality of life, then we can use some of the antipsychotic that block dopamine, but are less likely to cause a lot of problems with Parkinson's. So each of the medicines have different abilities to kind of cause Parkinson's side effects. And some of the first generation agents like haloperidol or Haldol are notorious for really making Parkinson's worse. We definitely avoid those. But these are a couple of names where they have less Parkinson's side effects. And then just recently in the past 5 years, there's a new medicine that has a different mechanism, Nuplazid or pimavanserin, that's FDA approved for hallucinations in Parkinson's disease that doesn't make the Parkinson's features worse. So that's an option. When it comes to the psychiatric symptoms, there definitely are medicines for depression and anxiety. The same ones are used for other people that have depression and anxiety. For this sleep disorder, a very safe option is taking melatonin before bedtime nightly. Can decrease some of the dream and acting behaviors, but for more severe and problematic acting out of dreams, we often use clonazepam. And then there are medicines for the orthostatic hypotension. Often we'll try non-pharmacologic approaches, which is trying to keep hydrated, using support stockings, and then usually looking at your other medicines, which might be making it worse, and trying to stop or change some medicines that might be making it worse. And then there are some medicines to add to help. I just listed a couple treatments on the constipation side. All right. Mentioned delirium, the sudden confusion. We'll have a talk from Julie Pavelka about hospitalization and sort of the approach. But usually we try to get things as normal as possible. So what happens when you end up in the hospital is they wake you up every hour to check your blood pressure. You don't get sleep. There's no lights. You can't hear. You can't see. And trying to normalize all of that will help. You don't recognize people. And then a lot of this medication adjustment is going to be on the providers. They're providing care, but trying to minimize new medicines, keeping some medicines on board and trying not to add a lot of new medicines are all things that can help people recover from this sudden confusion. I'm just going to put this up to say there's a lot of excitement and new research going on and new developments. I'm going to leave this to Dr. Goldman this afternoon to kind of talk about the future with Lewy body dementia research and treatments. But just a few highlights. There's a lot of work going on trying to find better tests to pick up Lewy body dementia more specifically to know for sure somebody has it, as well as early. There's also an interest in picking up signs and symptoms of someone destined to get features of Lewy body dementia at a very early stage. So we call it prodromal, where there would just be some very subtle signs. And we think with all of our treatments in the degenerative conditions, the earlier the better to try to intervene with treatments that might slow down the process. So that's a big focus. And then just recently, there have been some important new national clinical trials trying to find new medications specifically for Lewy body dementia. So that's excitement that there's some new developments. So I want to just close with a couple things happening here. And there's a couple research projects at the Med Center that certainly people could participate if they're interested in. This first one is a kind of a biomarker study, trying to figure out this idea of finding some early changes that might be a signal that someone either has or is going to get Lewy body dementia. So they're using an instrument technology called a magnetoencephalogram or MEG, which is very similar to an EEG, electroencephalogram, to measure brain activity on the surface of the brain. And so trying to see when they give a stimulus or just record brain activity if we can see some patterns and responses that would be kind of a signal. The other thing the study is doing is having people wear an activity monitor. It's like a Fitbit kind of watch for a couple of weeks to monitor their daytime activity, but also to monitor their sleep. And we know that changes in sleep can be a marker of Lewy body dementia and changes in mobility. And so practically for this study, it kind of involves 2 visits to the med. The first one, they kind of introduce you, get consent, show you the MEG and EG and kind of what that's involved. We do memory testing, and then they have you wear your Fitbit. And then you come back 2 weeks later, turn in your Fitbit, and then that's the day you get scans, the MEG, the EG, and the MRI. So that's one study. It's kind of a pilot study. We're just in the beginning stages to see how this technology might be helpful. So it involves patients that have a dementia with Lewy body diagnosis, Alzheimer's disease diagnosis, or frontotemporal dementia. And the second one I'm excited, it's our first clinical trial for people with dementia with Lewy bodies at the Med Center that I've been involved with. And it's called the Rewind DLB. Neflamapimod is the drug name. It's shown some promise in phase 2 studies to help both cognition and mobility. So this is a clinical trial. So you'd have to have kind of an official diagnosis of dementia with Lewy body. And then there's some biomarker tests that are done. One's called a DAT scan. Some people have had that, but many have not. So that would be part of the screen to see if you're a candidate. And they're also doing a blood test to kind of see if there's signs of Alzheimer's changes also. So if there's a lot of Alzheimer's changes for this study, someone wouldn't be a candidate. So it's trying to get the patients that just have the Lewy body changes. If you kind of qualify for 4 months, you would either be on this experimental medicine or placebo, and you don't know and we don't know. But after the 4 months, everybody can go on the medicine for 8 months. So it's a 1-year commitment. 4 months, you're not sure if you're on the medicine as we try to learn how much it is providing benefit versus placebo. In 8 months, you would get the benefit of seeing if it provides you benefit. So that's this Rewind DLB study. And so that's something that we're happy to talk to you about. That sounds of interest. All right. So I'm going to close with this. So a couple years ago, we received a very generous donation to the NU Foundation to develop a Lewy body initiative. And the idea and the goal was to enhance clinical care for patients that have Lewy body dementia, to build educational programs for patients and families, which this would be an example of, as well as providers at every level about Lewy body dementia, and then also to kind of launch and begin to do more clinical research in the area of Lewy body dementia. So we have arrived 2 years later to kind of see the fruits of that generous gift and that initiative, and the expectation is we'll continue to have success and move down this road. But so we think the past couple of years there's been a lot of progress in building some innovative clinical programs, educational support programs, which you either know about or hear about today, and then some of the research that started. All right, I will stop there, and I hope you heard the second half, but I'm sorry about the first.
As most of you know, I'm kind of loud anyway, so to mic up, I might be a little extra loud. Welcome, this is awesome, this is awesome. So happy to see so many people here. We also have the webinar via Zoom, so I know that we have 30 or 40 people at least on that, and the program is also being recorded. So if you want to watch it and rewatch it again, you're more than welcome to do so. So I'm going to talk on the pearls of hospitalization with Lewy body dementia. And oftentimes we fear hospitalization because we know that it can worsen symptoms. So today, I want you to all feel comfortable knowing that hospitalization can be in more of a controlled environment, and hopefully we can be proactive to try to avoid some of the issues that we have. We have a few objectives today. We're going to identify the pertinent information and documents to have organized prior to your hospitalization. Identify reliable resources. I'm going to give you guys a lot of different resources that you can use, and plan for hospitalizations and emergency department visits, which again, we hope to avoid, but they're certainly not always avoidable. And then I want you to all to be able to demonstrate knowledge of medications that can make symptoms worse. And it's our job to educate our healthcare providers because Lewy body dementia is very underdiagnosed. A lot of people just do not have the education, and it's not their fault. Everyone has their own specialty. I certainly wouldn't want to be responsible for delivering a baby or taking someone's gallbladder out. So we all have our specialty, and that's why our team is here, and that's why this team was developed at Nebraska Medicine, so that we have experts in this field to use as resources. Terminology is always an issue with a lot of my patients. They always want to know the difference between delirium and delusions and hallucinations. And so the terminology isn't that important for you to be able to memorize these terms and to be able to come in and say, my wife, my husband, my father, my mother is having, I think they're hallucinations. Just tell us what you're seeing, tell us what they're feeling. But the important thing is these three words are what get us into trouble with hospitalizations and ER visits. So that's why we're going to have a little bit more discussion on these three terms. So delirium, and Dr. Merman pointed this out a little bit ago, it's a very complex neuropsychiatric group of symptoms, but it's more acute. So it doesn't happen gradually over time, over 1 week, 2 weeks. It happens very abruptly, 24 hours, 48 hours, 72 hours within, say, a urinary tract infection or pneumonia or after post-surgical, et cetera. We know that people who have Lewy body dementia are much more susceptible than other types of dementia to develop delirium during hospitalizations and with acute illnesses. Unfortunately, recent studies have shown that individuals who do develop delirium are much slower, much more delayed to return to their baseline, and oftentimes do not return to their baseline. Hence the reason why we want to prevent any episodes of delirium that we possibly can. So delusions. Delusions are a strong belief, a false belief that's not based on logic of evidence. It's the most common are paranoid and persecutory delusions. Many of your loved ones have probably suffered some type of a delusion. Maybe it be mild, maybe it be severe, or anything in between. Some examples of delusions are thinking that a deceased loved one, a family member or friend is still alive, and they may even hear them in their house or in their bedroom. Feeling that or believing that a spouse is having an affair. Believing that a loved one has been replaced by an identical imposter. This is called Capgras delusions, and we do see this often where there may be two wives or two husbands that have the same one. Once in a while, there's a good one and there's a bad one. Most people like to be the good one, but unfortunately. Believing food or medicine is poison. So you'll put something in front of them and it was always their favorite food, and all of a sudden, why aren't you eating your meatloaf? You love meatloaf, but there's something in it. It's poisoned. I can see that tomato in there and think it's some sort of poisoning. They believe that strangers are living in the house, or they believe that parties are going on, and the parties can get pretty wild sometimes, so they are very believable. The next term is hallucination. The hallucination is more of a perception of a person or object or event that is really not present. Typically, they are visual in nature. However, they can be smell, taste, touch, or hearing things again that aren't there. Maybe seeing an animal or a person in a room. However, you do have to use caution with this, as I have had a patient previously that convincingly had a bat in her room, and she had a little bell that she would ring for her husband. He slept in another bedroom. And so she would ring her bell when she needed him. Well, there was a bat in her room, and so she was ringing her bell, and her husband went in and called her by name, and he said, honey, there's not a bat. I know you see that bat. It's time to go to bed though, and you know, we'll deal with it in the morning. I'll check in the morning just to make sure that there aren't any bats. Okay, so she went back to sleep again. Sure enough, she wakes up again, rings the bell. I know there's a bat in here. No, there isn't. So he sat in the room for a little bit, thought she went to sleep, snuck back into his bedroom. Guess what? A bat woke him up. So there was a bat in his bedroom. So you have to use everything as a kind of a grain of salt. So there truly was a bat, and he was the first one to tell me the story as she nudged him and said, "Are you gonna tell her about the bat?" So that it does happen. Some people, they'll be eating a food and it can be completely normal, but it tastes spoiled to them, or it has an off taste. And again, like Dr. Merman pointed out, COVID has really complicated that because people's taste and smell has changed so much. Well, if you're having hallucinations, it can complicate it even more. Seeing patterns on a rug. So any kind of rugs, even the carpet that is in here, can appear as a snake or a lizard, and it can appear to be moving. So we always like to have, you know, the nicest carpet that's just plain, or wood floors, as easy as we can keep the environment around the best for our loved ones. A coat hanger or a coat rack can be mistaken for a person. Vases or pictures in their bedroom or around the house can be mistaken as people or animals. So always look around your house and your environment and see what does somebody see from that? What could they see from that? There's been lots of articles, so now that you have a feel for those three terms that get us into trouble during hospitalizations and illnesses, there's been a lot of different studies on what causes crises and what kind of crises do we want to avoid. This particular one, Lewy Body Dementia, Caregiver Burnouts and Unmet Needs, looked at 962 caregivers over a 2-year period. But the question for the study was presented to caregivers: have you had to deal with a crisis situation with the patient in the last 1 year? 962 caregivers responded. 64% reported a crisis situation. And the most frequent place to seek help for the person with Lewy body dementia was, number one, the hospital emergency room. There were 296 visits. And number two would be emergency medical services or law enforcement. And the third one was an inpatient psychiatric care. So very, very interesting. Lots of ER visits and nowhere else, to go. This next study is causes and outcomes of hospitalization in Lewy body dementia. It's a retrospective cohort study that demonstrates the common reasons for hospitalizations. The idea, the introduction, and the methods of the study was to identify common causes, the medication profiles that each individual patient was on, complications, and then the outcome of LBD. This was completed, this part of the study was completed at the University of Florida, which is also an academic medical center as UNMC. The retrospective short study, that one was over a 2-year period of time. So with LBD, on that one there were 178 hospitalizations, but only 117 individuals, as there were repeat hospitalizations. So the number one reason for hospitalization was neuropsychiatric symptoms. 40% of the reason of hospitalizations in this study. The number two was falls at 24%, and the third one was infection at 23%. So urinary tract infection, pneumonia, COVID, cellulitis, etc. And then the rest: GI disease, heart problems, breathing, lung problems, failure to thrive, urinary disorders, and then only 3% for elective surgery. So that is a very, very unique study. So more of the hospitalization details. 72% of the hospitalizations were to medicine services. So just like internal medicine or family medicine completed the admissions. 12% of the hospitalizations were to the neurology service. 8% of the hospitalizations were to surgical services. And 3% of the hospitalizations were to the ICU. 32% of the patients not admitted to neurology received a neuroconsultation or a psychiatric consultation. Now you know why we want to minimize hospitalization. 49% had delirium, which we talked about, worsening confusion or hallucinations. 49%, that is half of the people who were admitted had confusion that was worse or hallucinations. And just how we talked a few minutes ago, we worry about people returning to baseline after they have that delirium in the hospital. 17% developed in-hospital pneumonia, and 5% fell while in the hospital. I actually thought 5% was kind of low, just because of the dysautonomia, the blood pressure, and the confusion, the dizziness, et cetera, that people often experience. Hospitalization was longer when any of these complications occurred. So instead of a 3-day visit or 5-day, the median stay was 5 days, but it ranged from 1 to 72 days. 33% of the hospitalizations in this study resulted in transition to a higher level of care. So meaning somebody may have been in independent living and then went to either assisted living, memory care, or long-term care. 15% of the hospitalizations ended in hospice care or death. Hospital stays were longer in people with delirium and confusion that was present on admission and then worsened through the hospitalization if they developed, of course, pneumonia or falls during the hospital. And use of antipsychotic medications other than the quetiapine or clozapine, which Dr. Merman had also referred to. Antipsychotics were administered during 38% of the hospitalizations. So the conclusion of the study was the most common reasons for hospitalization in LBD are potentially modifiable. And we have lots and lots of opportunities for improved care by increasing, specialists and other people to reduce antipsychotic use, delirium prevention strategies, et cetera, which we're going to talk about. Clinicians also should counsel patients and families that hospitalization in LBD can be associated with palliative care or so end of life. We need lots of research yet to identify strategies to prevent hospitalization and not have optimal standards for inpatient care. And we are currently even working on that at Nebraska Medicine. Okay, so now after all that gloom and doom, what can we do? So this is what we want to be. We want to be prepared. And oftentimes, things can happen and we don't have the opportunity to be prepared for hospitalizations. And that's why you are here today. Over the next week or two, you are going to go over your documents, and I hope everybody has a notebook. I know a lot of people who come to our monthly support group, support and wellness group, do have a notebook, and to keep all of the important documents in it and information that you want to share with others and that you want to teach others. So oftentimes, and these next slides I have taken from lbda.org, which is an absolutely amazing resource for you. You all should highlight it, black, bold, capitalize it. It has so much information. Their webinars are fantastic. We use their webinars in our support group, and I know several of our caregivers are involved in the caregiving sites and the information. It's all free. It's free to you, and the resources are they're just invaluable. But that's where these next few slides came from. Oftentimes now during intake, and a lot of times if we're preparing for a surgery or something, a nurse usually calls 1 or 2 or 3 days ahead to do kind of the pre-op, pre-admission type of questions to save time during the morning of admission. And it's really important that as their advocate, as their care provider, whether your husband, wife, daughter, family member, to make sure you, of course, know your loved one's history and be able to tell the intake person about Lewy body dementia. This is your chance to educate them and to tell them, what they need to know. You want this marked and flagged on their chart so that people from nutrition services can look at it, people from anesthesiology, people from labs, that everybody has this somewhere on the chart where they can see it. Another thing, you want to inform the intake person about the medication sensitivities. And before you all go home, you're going to know all of the medication sensitivities. A lot of you already do. But the multiple medication sensitivities tell them what medications your loved one can and cannot have. And we're going to have some handouts here in a few minutes. I'm going to show you that you can acquire. And make sure that there's a wallet card from the LBDA. It looks like this, and you can all get it at the lbda.org site again. In fact, we might have some. Dr. Fargo is here from LBDA. Dr. Fargo has the medication cards at his table out there. So thank you for bringing those. These cards are miraculous. You should have several of them. Everyone in your family should have several of them. Anyone who could possibly be taking care of your loved one, whether they go to perhaps a daycare during the day or when they go to therapy, et cetera, in case an ambulance has to be contacted. But this outlines the medications that they absolutely should not have, and also discusses the neuroleptic malignant syndrome that can occur and be a cause of death if patients do receive the wrong medication. So please, everybody get a medical alert card, or 2 or 3 or 10 before you leave. So preparing for hospitalization, again, it's important to contact the provider who takes care of your family member, whether it be their memory disorder specialist, whether it be their internal medicine, whoever knows your loved one the best. Contact them and make them aware of the hospitalization. And if they have affiliation or admission privileges or et cetera at this particular hospital, ask them to stop by and maybe even glance over the chart to make sure that there aren't certain medications or things that are ordered that shouldn't be. And again, nobody means any harm when they order things. We have a lot of hospitalists in the different hospitals, and they don't, we're not overseeing them, we're not second guessing them, but it's more of an education opportunity. And again, to be more proactive than have to be reactive. Meet the treating provider, even if they are only doing a colonoscopy. A colonoscopy is still a procedure. Your loved one still receives IV sedation of some sort to have a colonoscopy. Meet the anesthesia person. Say, hey, I just want to reiterate, and you're not being a nag. You are being proactive. You are taking care of things before they could happen, before consequences could happen. Also find out when the doctor makes rounds, when they're going to come out and talk to you, and try to be present during this time. And oftentimes it might be a 2-hour gap. That's fine because they're making rounds on several patients. But at least ask the nurses, what time do you think that Dr. So-and-so or nurse practitioner so-and-so will be making rounds? This is key. Work with the nurses. Nurses are your friends. I say that very lovingly. Being a nurse myself for 30 years, they are your friends. They are the ones who are taking care of the patients, the providers, the physical therapists, the pharmacists, the surgeons, whoever. They're in and out, they're in and out, they're in and out. They are taking what the other providers, specifically the nurses, are telling them as far as updates on your patients. They are the ones that are giving medication. They are the ones you need to say, hey, they really need to have this medication at 9 a.m. I know that you have an hour leeway per state guidelines that you can give it at 10 or 8, but they really need this medicine at 9 o'clock. Otherwise, it can wear off and they can have, some hallucinations. They might not be able to move as well, etc. Also, always inform the staff of your contact information, your cell phone number, whatever way that they can reach you the easiest, so that if there is a problem, then they can contact you quickly. A lot of times, two numbers, a child or somebody else's that they can have, so they can always get a hold of somebody. Also, if there are any medication changes, every day when you go in, you can ask to see the medication administration record. Are there any new medications that my loved one has started on? Were there any medications that were discontinued? Because again, we're educating the staff. We're not trying to be mean, or we're just trying to be proactive, and we are their advocates. Try not to use any naughty words here. So, but we're not nagging. We're being proactive. And again, invite them to call you if they have any questions or concerns whatsoever. Here's the big slide, and I know there's a lot of words, but be proactive. Try, if you can, to have a family member with your loved one in the hospital during the hospital stay, because being in a different environment, you're getting awakened for vitals, your walls look different, your bed feels different, there might be a TV on, there's noises out in the hall, there's call lights. There's a lot of different routines that go in the hospital that completely flip people and result in the delirium. So if you can have a family member there at all times, please do. If a family member cannot be present, there are sitters frequently in hospitals that are available to come and sit with your loved ones. And again, if there is a sitter, it is your job to help with education of your loved one. Alert the staff to concerning changes. You know your loved one better than anyone. And what I might think is not unusual behavior or something that might be normal for them, you know that it's not normal for them to be playing and picking in the air or something. If that is something you wouldn't expect from your loved one, say, hey, you know, I noticed that John here he's picking in the air a little bit, and that's not normal for him. That, you know, that's really unusual. Should we kind of review, you know, some things? Do you think, you know, did he sleep well last night? You know, sleep deprivation is a huge issue for delirium. Always be patient, of course, and be kind and not condescending, but just make sure that the staff do know that there is something different about your loved one, and this is not their normal. So if there are problems, which of course we hope it doesn't lead to this, but if there are problems, a problem resolution would be to, first of all, start with the nursing staff. Nurses are your friends. If that doesn't go anywhere, then you might need to ask to speak with a charge nurse or the director of nursing. And then some hospitals actually have patient advocates, which is another resource to the charge nurses. But try to remain calm and understanding and patient. I know nurses are so busy these days. They have a lot of patients to take care of, and you again are the advocate. So not only does lbda.org have amazing resources, the Parkinson's Foundation also has absolutely amazing resources. And again, their website is completely free. Everything that you can order, information is free. And this overlaps a lot with the Lewy Body Dementia, because as you all know, a lot of patients started out having Parkinson's disease and then developed the dementia, Parkinson's disease dementia, also called Lewy Body Dementia. This Aware and Care Hospital Action Plan, I have the link for you to be able to download. It is a 24-page document that is absolutely amazing. That is a complete hospital plan for you to have completely filled out before you ever even go to a hospital, so that you can make sure you have all of your T's crossed and your I's dotted. There's 10 different steps that provide optimum care, and those are all going to be listed in that document. A lot of you have been exposed to the Aware and Care kit, and this is through the Parkinson's Foundation, and it looks like this. And again, these are completely free through the Parkinson's Foundation, and Sherry Prince actually had some of these and can get any information that you would need from this. But it has these amazing cards, and it's a fact sheet for nurses. And there are many of them. And if you need more, you can order them for free too. And I think Sherry can have the information on that. So these cards, you just rip one off, put it in his chart, please. Put it in her chart, please. And also make sure your family members and everyone have these. But there's a lot of great information in these Aware and Care kits. And again, they're free. I mean, there's a bracelet, there's different things on medications, etc. And not everything, you know, might apply to your loved one. But again, everyone should have something similar to this, of course, to take along with your 3-ring notebook of all your teaching material. This is just the medication list that's in there that I showed you guys, that you're all going to have a copy. Okay, so this is a tough topic. There's risks and benefits for elective procedures and tests, and these need to be discussed at length with your providers. So if they do have to have a procedure, is it an option to have a regional block? Is it an option to have spinal anesthesia, or do they have to have a general anesthesia? Because we know with general anesthesia, we're at a little bit higher risk for acquiring a post-operative delirium. So my mom's going to have a total knee done. Can she have a spinal anesthetic so we can avoid general? That would be a question. Some of the shoulder surgeries, you can have, more of a regional block, or for example, a carpal tunnel surgery. You can also do like a regional block. Will the procedure that you are wanting done improve the quality of life? Or is this just a procedure like, meh, I'd kind of like to go have a surgery. Let's go ahead and go to the hospital. Is the procedure going to improve the quality of your loved one's life? Would the results of the procedure or test change the treatment, and would you pursue the treatment? So for example, with malignancy. So if you have colon cancer that has metastasized, would your loved one want to have a bowel resection and a colostomy, perhaps? I don't know. There's not a right answer. There's not a wrong answer. These are things that you want to think of before you go into any kind of a procedure. Or you need a pacemaker. If you do not have a pacemaker, your heart is going to go into a complete heart block and you're going to die because you're now an asystole. You're flatline. Well, you probably better have the pacemaker then, right? So it's looking at that, like I'm talking about the quality of your life. Discuss all risks with your providers. And oftentimes we have patients that's the reason for their visit is their loved one needs to have something done, and they want to discuss what's your opinion, what's the pros, what's the cons, and what's the risks, what's the benefits. And we sit down and we talk about that. So your mother can't walk and she's completely non-ambulatory because the arthritis in her knee is so bad. She has bone on bone, and you're going to have to wheel her around in a wheelchair if she doesn't have a total knee replacement. Quality of life benefit. Do we take the chance that doing a total knee is going to improve the quality of her life? And if she can be more ambulatory and not so sedentary, that will be better off in the long run. These are just things to think about. Again, there's no right or wrong answers. Of course, we do have a beautiful emergency department at Nebraska Medicine, but we want you to avoid the emergency departments if you can. But if you need to go to the emergency department, we're going to help you out a little bit. Also on the LBDA site, there is information on emergency room treatment of psychosis. And again, this is our opportunity to educate the providers that are taking care of our loved ones. You can download this and it should be in your notebook to provide to the providers that are taking care of your loved ones. This is emergency room treatment of psychosis, and this basically just outlines what medications they should and shouldn't have, the things that we need to look at. Are there infections? Are they on bladder medications like anticholinergics that could be making their symptoms worse? Are they on any other medications that could be making their symptoms worse? And then reviewing what medications that they should avoid. And if you don't learn anything else from this talk, I want you to put Haldol as an allergy on every one of your loved ones' medical records. Haldol is actually contraindicated and has resulted in death in patients with Parkinson's disease and Lewy body dementia. So if you ever hear that word Haldol or haloperidol, it's a red flag. Okay, I'm going to finish up with a few pearls, and these are Julie's pearls. These aren't pearls from anywhere else. But these are the things that I really want you to discuss with your loved ones and have in your notebook before you have any procedures or possible hospitalizations. Have your powers of attorney completed, financial and healthcare. Sometimes we have one child via healthcare, one child via the financial. It doesn't matter, but have your power of attorneys done. Have a living will done if you can, and discuss with your family or friends early. What do you want? We have lots of conversations with our patients, if they're having, for example, difficulty swallowing or choking, and then they're getting aspiration pneumonias. Well, do you want to continue with the hospitalizations and treatments of the pneumonia, or should we talk about a feeding tube? Some people, no, I absolutely do not want to feed. Okay, your wishes. The other person, like, yes, I am ready. I want to feed So these are discussions that we don't want to wait until it's too late or until we're in a crisis situation to try to make. Update all of your health history. As you guys know, many people have very complicated health histories. You don't just have necessarily Parkinson's disease or Lewy body dementia, but maybe you have a valve replacement, or maybe you have a coronary artery disease, maybe you had a stroke, maybe you have diabetes, but make sure your medical records are updated and you have a copy with you. Make sure all of your medications that you have lists. And oftentimes people will bring in their bottles to their appointments, and they'll say, yes, but wait, I'm not taking that. Oh, I'm not taking that way. Oh, I'm taking 2 of that one. So, and it's okay. I mean, you're taking your medications the way you're taking it, but make sure that is documented on how you are taking your medications, because again, one medication error or not getting enough medication or getting too much can cause the delirium that we're trying to avoid. Routine, routine, routine. Anybody who knows me knows that routine with my patients is preached frequently. Trying to get up at the same time, trying to eat at the same time, trying to take our medications at the same time, going to bed. During hospitalization, routine is destroyed. But we have to try our best to keep their routine in the best order that we can. And if they're used to watching Good Morning America every morning, try to get Good Morning America on for them. If they're used to taking a nap at 1 o'clock, maybe you could ask the staff, hey, this is John's nap time from 1 till 2. Can we try to keep it quiet? Can we try to, okay. So try to keep them in routine as much as possible. And it's impossible. It's not even possible to keep them in their normal routine because they're in a completely different environment, but try. The next one, yeah, Haldol. Never, never, ever, ever Haldol. And the last one is be proactive and listen to your intuition. If you have a gut feeling that something doesn't seem right, it just doesn't feel right, it's probably not right. So listen to that gut. Even if there's nothing outward that you feel that way, you don't have to see something. You don't have to see somebody bleeding. You don't have to see somebody having a fever to be concerned. If you have that feeling, that intuition, listen to it and make sure you're talking to the providers. All right, it takes all of us. It takes all of us. We are a team, and we keep trying to put this puzzle together, and we're gonna keep working at it. We'll take questions at the end of the day after Dr. Goldman speaks. So you'll have plenty of opportunities. We'll take mics around so that you don't have to yell at us or anything. So we got the morning now. You all had cards that I gave you. So we're going to go ahead and proceed with the morning break. And I see a lot of rolls and fruit and stuff on the table yet. So I encourage you, as you all know, I love my sweets and my treats. Everybody at support group, I'm always encouraging them to take 2 or 3 or 10 of the sweets that we have there. But I want you to eat up your treats, drink some water, get some coffee, whatever you like. And then when you return from the break, we're going to be separating into our breakout groups. So I know some of you don't have index cards, and in a couple minutes here, I'm going to have you raise your hand and we will get you the index cards. The colored index cards are for our Lewy body dementia warriors. What's a warrior? A warrior is a brave or experienced soldier or fighter. And we use the word all of the time, our Lewy body dementia patients, or people with Lewy body. The new term in my world is warriors. Warriors, welcome to our tribe. So the warriors are going to have a colored card, and it's going to have a number on it, okay? And on the tables, we're going to set out pieces of paper that have numbers on them, and we will direct you to the table after you come out from break. And if you guys just scoot your stuff up on your table just so people can sit there, and please try not to be kleptomaniacs and carry off with anyone's belongings. And then the groups are going to they should be 6 or less. And if there's not 6 or less at your table, we'll try to help you regroup. Also, the white index groups, these are for the warriors, care partners, families, and friends. So this is for the rest of your tribe. They also have a number on those cards, but they should be white cards. And we're going to, again, on the tables, there will be a number that corresponds to the number on your card. On the cards, they all have the same question when you flip them over. There's a question, and you're going to go around the group, and the question's all the same, and you're going to discuss that question in your group, okay? And the idea of this is just for you to get up, go to break, have a stretch out, get to meet other people in the room. So it's more of just a exercise to meet other people. Don't get into any too intense of conversations. I'm gonna have to talk to a couple people I know will get in intense conversations. And then we will, if you could be seated in the groups by about, in about 15 minutes or so. And then we'll have everybody return to their tables by 11:30, and I'll come up and announce it. And that'll be our last session before lunch. So actually, we'll go back to the tables about 11:15, just so everybody can get situated. Okay, so carry on. Okay, we're going to go ahead, and I know that a lot of you have had some very therapeutic conversations. We're going to go ahead and separate back. You can go back to your tables that you came from, as that will be where we'll have one more speaker, and then we're going to have lunch. So thank you, everybody, for participating, and we'll help move chairs and things. So just tell us where you need to go. So this
Jeanette.
is, yeah, she goes by Jean.
Oh, okay, yeah.
Got it?
Please.
And then, and this is the on right here. I have it off.
Yeah.
Yep. You're out for him. Help you. Is that okay? Can I help you?
Yeah.
Looks so pretty.
Okay. What do you?
Just when you're ready.
Oh. Yeah, you tell me whenever.
Okay, we're gonna go ahead and get ready for our last session before lunch. If everybody wants to return to their seats, and nobody picked up anything and returned to their table with belongings that weren't theirs, did they? I don't see anybody raising their hand, so, okay.
Okay, hi, good morning. My name is Colleen Horty. I'm a social worker at Nebraska Medicine with our neurology clinic and our memory disorders team, and very happy to be here today. I was asked to share some resources that might be particularly helpful. So go ahead and get started. So I know that there are lots of different resources out there. As a social worker, I use these all the time in connecting people to different things that might be helpful. So just a little disclaimer, these are, not all encompassing, not an exhaustive list, but ones that I think can be particularly helpful around this time. So I do love finding out about new resources. So, if you see me after and think of something that's been particularly helpful for you, please let me know. So I'm going to do this sort of David Letterman style, and these are my top 10 resources to help navigate Lewy body dementia. So number 10, I am not sure. I often find when I'm talking to folks that people are not as familiar with help equipment. Some of you may be, but they are an agency. They used to be in the old Center Mall here. Now, a couple of years ago, they moved out towards Ralston. They operate a loan equipment closet. It's gotten to be pretty big. They have lots of different things for low cost rental or purchase. They're all gently used. There's things like wheelchairs, rollator walkers, shower chairs, bath benches. They also have things for a closet for donated supplies. So Boost, Ensure, lots of those things that can get pretty expensive when you're using them on a regular basis. So I often encourage people to check them out and visit or call ahead. I know some of the things you can get using a script, certainly from your doctor, like with a wheelchair or walker. Sometimes people might want to try something out to see if it's even worth it to get for them. So the other piece, sometimes lift chairs, things that get to be a little pricier, or hospital beds, they sometimes have in stock. So always want to make sure people know about them and check them out if that's something that might be helpful for you. They do offer a long-term care planning program. It's pretty small, but especially helpful if you have Medicaid and are starting to look at a long-term care community. Number 9, this is the Department of Health and Human Services. I put the website for the one here in Nebraska, certainly in Iowa. They also have their Department of Health and Human Services that offer some similar programs and services. But they have a lot of different programs for all Nebraskans. Certainly for people with a lower income, they have things like that might help in terms of emergency assistance or ongoing financial assistance with food, energy assistance. But they also fund Medicaid programs that can be helpful if you're starting to need more care in the home or needing a long-term care community. And if you have Medicaid, there are some specific programs that can help with that through Medicaid waiver. They also operate a lifespan respite program that can be really helpful for people who need a break from caregiving. That's something that's offered through the state as well. And then I always want to make sure people know about the long-term care ombudsman. If you have a loved one who's in assisted living or a nursing facility, the long-term care ombudsman is a person who is a liaison between families, between loved ones, and the facility. So I always want to make sure you know about that in case there are concerns or things that you're wanting to address with the administration. They're a really good resource to know about. Okay, number 8. This is the state health insurance program, also called SHIP. They are a federal program that are operated by different communities and organizations. They're throughout Nebraska and throughout Iowa, depending on where you live. But they are a really good resource if you for Medicare counseling, free, unbiased questions and guidance around Medicare. We all know that Medicare has become a little more complicated in recent years with the initiation of Medicare Advantage plans. There's lots of different programs to choose or plans to choose from. Part D, there are a lot of prescription assistance. There are lots of different plans to choose from. So if you are going to be new to Medicare, if you're going to be turning 65 soon, or if you're going to be getting Medicare as a result of Social Security disability and having had that for a few years, I encourage people to reach out to SHIP. You can make an appointment with their counselor there. They can sit down with you, talk about the different medications that you're taking, talk about which health systems you go to or what plans, what physicians you want to make sure are in network. They also can help people around open enrollment time with potentially changing plans. So if you're enrolled in one Medicare Advantage plan and you haven't been as happy with it and are thinking about changing, SHIP is the agency to talk to. We are almost at open enrollment next week for Medicare, so this is a busy time for them. If you call them, you most likely will have to leave a message and they will call you back. I'm not sure how, they're just very busy right now, but they're definitely a good resource to talk to, and always want to make sure people know about them. Here in Omaha, the agency that is the SHIP agency is called Volunteers Assisting Seniors, and they cover Douglas, Sarpy, I believe Cass County as well. Okay, number 7, these are lots of different programs available to veterans. Always one of the questions I always ask when I'm meeting with people or talking with people for the first time is, are you a veteran? If you are not sure if you may be eligible for different programs or services, I think a really good place to start is the County Veteran Service Officer. Each county in Nebraska and Iowa has one. You can meet with them, talk about your service level, when you served, what branch you served with, and they can talk to you about potential benefits that you might be eligible for. They also have a couple of newer caregiver programs, and so I put down the number here for the caregiver support line. Couple different programs, again, based on disability level, service connection. But I always encourage people to reach out to them and see if there are things that might be helpful for you. If you know that a family member has served, but you're not sure of their discharge status, or if you've lost your DD-214 paperwork, the County Veteran Service Officer is an agency that can help you work on that and find out the paperwork that you might need for eligibility. Number 6, these are different senior living advisors, or sometimes called housing navigators, and they are private companies. I do not endorse one over the other. I actually copied the list from our Nebraska Medicine geriatric clinic. They have a list of different agencies that they have down. So I've definitely heard of multiple people who've used several of these different agencies and had really good feedback. If you are at a point where you're starting to think about potentially moving to independent living or assisted living or looking at memory care, and you're not quite sure where to start, I think that sometimes in certain situations, these are groups that can be helpful. They don't charge a fee to you. They get their sort of finder's fee from the communities that they refer people to. I think they can be especially helpful in situations where you're needing to move quickly, or there are some particular details that you want to make sure that you find a community that's a right fit. Whether you use any of these agencies or not, I definitely encourage people, if you are starting to think about looking ahead to long-term care, I encourage people to start sooner rather than later. That way you can get a good feel for a place, you can set up some tours. These places will set up tours for you or set up a lunch. But it's always good to start sooner rather than later. That way you can make the decision that's best for you, and not feel like you're so rushed that you have to do something super quickly. Number 5, these are kind of just general with care partner resources, but I put a couple of agencies on here. One of the things that I talk to a lot of folks about, and this can look very differently for people, is respite care. We know that if you are a care partner and providing full-time care, we know how important it is for you to have a break and some time away. So these are organizations that have a lot of information for caregivers, tip sheets, different web series, educational offerings for folks. And they have a lot of information on kind of initiating different things. But respite care is something that can look very differently. It could be somebody coming in to give you a break, spend time with your loved one while you get out and go to different appointments. It could look like an adult day program once or twice a week. Again, to give you a break and to provide that social engagement that we know can be so important. So these are, again, 2 care partner resources and supports that I encourage people to check out, that I think can be really helpful, and they're written in a way that lay people like myself can understand and find help. Okay, so the number 4, advanced care planning resource. Julie mentioned earlier the importance of getting your advanced directives, living will, healthcare power of attorney in order. But sometimes that can be a difficult thing to either bring up with family. And so these are 2 organizations here that are websites that I think can be especially helpful in terms of starting the conversation. I know for myself, I've mentioned to my husband before, okay, we need to think about, or I'll ask him, what would you want? Would you want this or not? And he is very, oh, that's morbid. Oh, I don't want to think about that. But we know how important it can be to talk about those things ahead of time, and especially when we have a specific diagnosis. So these are the Conversation Project, is a website that has lots of information on just prompts, starters for families to think about for themselves, or to start asking your loved one. The other piece that I think is especially helpful is when Okay, so we're talking about planning for long-term care. But we all know that there are costs associated with that. And so one of the things that can be especially helpful is to talk with an attorney about who, especially one who's focused on elder law. Sometimes there are programs and things that they can set up that can help look ahead to those long-term care costs, potentially knowing that maybe at some point you might need to apply for Medicaid. And so if you see an attorney that's one that's advertised more as an elder law attorney, those are ones that have a lot of experience in that area and can help with that. Okay, disease-specific organization. So I put down a few on here that I think can be especially helpful for people with Lewy body dementia and their families. Certainly, we'll have a talk this afternoon from the LBDA, but I have found a lot of these organizations really helpful for me in terms of learning, and I think very helpful for our caregivers and patients as well. They have things like tip sheets, caregiver supports, certainly support groups with our group out at Heartland that can be really helpful for people getting that connection from other people, and they help sponsor things like today and make things like that possible. But we know how helpful it can be for other family members to get that support. The Lewy Body Dementia Association has a Lewy Buddy line. They have their helpline. Certainly the Alzheimer's Association has a 24/7 helpline too. So I encourage people to really, if you aren't subscribed for these different organizations, email newsletters, I definitely encourage people to do that. I get a lot of information myself that way, or I'll try to sign up for a webinar sometimes that might be helpful. But really important organization. Okay, number 2. These are area agencies on aging. These are organizations that I refer people to quite a bit. Some of you may be familiar with them. They were funded through or covered by the Older Americans Act, and so they are federal, they are national, but operated by different local organizations. So here in Omaha, our agency is the Eastern Nebraska area or Office on Aging, NOS. In Iowa, it's called Connections for the western part of Iowa. I put down in Lincoln and surrounding counties, it's called Aging Partners. They are kind of a good starting point and offer a lot of different things for people 60 and over. So certain programs like Meals on Wheels, personal care programs, homemaker services. One of the biggest things that I often refer people to or talk to people about is their caregiver support program. This is one that looks a little different from area agency to area agency, but here in Omaha, the caregiver support program does provide some funding for respite care, whether it's in-home or adult day programs. And they also do some other educational opportunities and connections for caregivers. They also are, if you do have Medicaid and are starting to get Medicaid waiver services, they provide service connection and help with assessing and getting services started for people with that program. Certainly some of the programs are free depending on income. Some of the programs you might pay a smaller fee depending, they use a sliding scale sometimes. So it's always something I want to make sure people are aware of and familiar with, and certainly contact to see how they might be able to. And then the number 1 resource that I put down here are social workers. So that's me at my desk waiting for your call. they, like I said, I work in our outpatient neurology clinic, but we at Nebraska Medicine, I feel like we're fortunate to be adding more and more social workers to a lot of our outpatient clinics. And so certainly all of our primary care clinics have social workers that are connected with them. I know at some of the other health systems, they're starting to add more and more social workers as well. So on a daily basis, I work with a lot of different areas. So I might be talking to someone about applying for Social Security disability. I might be talking to someone about hospice services. I might be talking to them about adult day programs or transportation. So, I definitely encourage you to connect to whether it's me or another social worker. It can be a really good place to start for potential resources depending on your particular situation. Certainly financial assistance and some resources that might be just specific to your situation. So that is my talk, and I know it's a little early. I think we've started. Okay, thank you.
I recognize that laughter. Okay, we're just going to take a few minutes here. All right, lunch is going to be just in a few minutes, but you get to sit back and relax, and they're going to serve you your lunch, so you don't even have to go through like a buffet line or anything like that. So that will be very nice. Also, we have a photo backdrop here for your family photos that you may want on your Christmas cards. Yes, it's Christmas cards. So we are encouraging each of you, especially there are some of you that have several children here. You probably haven't had a family photo for a while. So it's time. And Sally, we're more than happy to take your pictures on your cell phones or whatever, but Sally Weathers, she's our event coordinator and planner at UNMC, Nebraska Medicine. And she also has a big camera if you don't have cameras that we can take pictures. Also, there's an authorization, a release that I hope all of you have signed so that I can use your photos in the future for our awesome Lewy Body Dementia newsletter and also the videos. As you see, we had a video today of patient groups and stuff. And one of our groups, we had this amazing dinner and this little two-man band play, and people were dancing and everything. And I had these great pictures, and Sally said I couldn't have any faces on the video. So because I didn't have releases of authorization. So hence you're going to be signing those like crazy, because I want everyone to see how much fun you're having and see your beautiful smiles when we're all together. So if everybody will sign those, and we can take pictures or whatever. All right. There's a couple things before lunch that I want to do. We have two special people that we really want to recognize from the UNMC, Nebraska Medicine Memory Disorders team would like to recognize. A little token of appreciation. The first recipient is receiving in recognition of outstanding leadership. As a colleague brought to my attention the other day, I have been a nurse for 30 years and a nurse practitioner for 19 years. I have worked with many physicians and healthcare providers. Some were amazing leaders, and some may have benefited from leadership training and some coaching. However, I have had the distinct privilege in the past 11 years working with a role model in leadership and a physician who doesn't relish in receiving accolades of praise. He is selfless, kind, and compassionate, and extremely intelligent. He is passionate about education and research, constantly teaching and guiding his patients, colleagues, and students. His leadership to our memory disorder team is far superior to most. As Douglas MacArthur eloquently said, a true leader has the confidence to stand alone, the courage to make tough decisions, and the compassion to listen to the needs of others. He does not set out to be a leader, but becomes only one by the equality of his actions and integrity of his attention. It is my honor to present Dr. Daniel Merman with our In Recognition of Outstanding Leadership. Thanks for all you do. And he is not an emotional guy, one bit.
And I'm embarrassed and I paid Julie. Thank you.
He is not emotional at all. We always say that in our program, he's the brains and I'm the heart. I'm the one that tears up and gets emotional. Stand up here for a second. Okay, next. Our next recipient receives with our greatest appreciation. As a wife, a care partner, a mother, a sister, a dear friend, and a nurse. This individual is the true definition of altruism. She is one of the most genuine, humble, kind, and compassionate people I have ever met. She is so patient and thoughtful, preferring to never receive recognition or praise. She has provided purpose to so many lives, including mine. Dear Linda Doherty, for all your unwavering support and unrelenting guidance that help in leading our path to success, you are being honored with much appreciation and gratitude.
Say if it wouldn't be for Julie and Dr. Merman, the journey that I took, they made it as easy as possible. And my husband thanks them also for all their great care. And they are forever in my heart and in my
All right, I think that's it before lunch. If you have any questions or concerns, we have our amazing staff here. Sally is in the back. Denise is our case manager on the memory disorder team. Jeff is our MA. Dawn is up front here. Colleen is still here. And then we have the Heartland Neurological and Wellness Group. So Amy and Sherry and okay. And Sean's out there. Okay. All right. So sit back, relax, and let's eat some lunch and have some more therapeutic communication.
All right, just one moment while I get the microphone taken care of. All right, how's this? Can everybody hear me? Even if I step away? How about this table here? Okay, real good. All right, excellent. Okay. Oh no. I tried, folks. Okay. So I'm here just for a few minutes to kind of tell you guys a little bit about the Lewy Body Dementia Association and what we do and why we were founded and how we were founded and hopefully how you can get to know us a little bit. We can get to know you guys a little bit. Yeah, so that's what I'm here for. And so first I want to say thank you to UNMC for providing me out to, yes, still can't hear. Okay. All right. Let's bring this up. How's this? All right, I'm going to try it this way. How about now? All right, I'm going to do this. How about that? All right. Okay. So greetings from Lilburn, Georgia. This picture here makes it look like that we are in the middle of the sticks in Georgia, but we're not. Lilburn is actually just a small suburb of Atlanta. So that's where we're located. Now, most of us are actually remote because that's the world we live in these days, but we do have a small team that actually works in the office in Georgia. So what do? Well, we provide education, research, and support for people living with Lewy body dementia and their families and their caregivers. And everything we're doing is to try to reduce the burden on people who have Lewy body dementia, make their lives as easy as we can as we work toward cures. So ultimately what we're trying to do is eradicate Lewy body dementia, but in the meantime, we want to make sure that everyone has the support and care that they need, and that the people who are providing care for them, their healthcare professionals, also have the support and education that they need to understand more about this disease so that they can be most effective in serving you. So how did we start? Well, we really started with a group just like this about 20 years ago. Actually, it was exactly 20 years ago. This is our 20th anniversary. And this person here, this is Angela Taylor. If any of you guys have been around LBDA for a while, you've probably heard Angela's name. She's my boss. She's currently our Vice President of Strategic Partnerships, and I work for her. She's been with us since 2004, so almost from the beginning. And this is her dad here, and he passed away from Lewy body dementia. And so that's really the animating force behind everything we do, was the realization that there wasn't enough support out there for people with Lewy body dementia. And so we said, well, we'll provide that. So that's how we started. So some of the programs that we offer, education is very important to us. I'll draw your attention to the webinar series. I think Julie mentioned it earlier. They actually use some of these webinars in the support group here. And these are free and available on our YouTube channel. So you can find those. You can also go to our website, lbda.org. You should be able to find those. If you scroll down to the bottom of our homepage, you're going to find a list of upcoming events. And so we have several more community webinars scheduled out several months in advance. And this is something that you're going to continue to see from us. So we've heard recently from Jim Galvin, who actually talked about the Rewind LB study, which they're running right here at UNMC. So something for you to look into. And then Samantha Holden from Colorado talked about vision changes. Jennifer Goldman here, who's with us today, who you can hear from, actually is going to do an upcoming webinar for us on the use of DAT scan, which is a kind of brain scan that is sometimes used in some cases of Lewy body dementia. So more to come. You can find all of that, like I said, on YouTube. And the other thing I'll draw your attention to, actually more video here. So another thing that we have is a program called Spark. And a lot of people, the first time they ever heard about Lewy body dementia was Robin Williams, unfortunately. And so many of you know that story. And his family was really generous to allow us to use some of that movie to create educational programming. And so Spark is an opportunity where we will view is not the right word, but we will present, I guess, for lack of a better word, this movie, and then we have some educational materials around that. So we talk about, okay, what does this mean? You know, what does it look like? What care options are available? What therapeutics are available, et cetera. So it's a way for us to start conversations. And most of these things are actually available. Sorry, I'm not sure how frequently to click to get to the right part of my slide. Most of these things are available on our Mediflix channel as well. So on Mediflix, you can see that Spark video. You can also see a video on understanding Lewy body dementia, which kind of goes through some of the basics, how it relates to Parkinson's disease, et cetera. That's with Dr. Jory Fleischer out of Rush University in Chicago. We also have a series of sort of shorter educational vignettes on Mediflix on specific topics that you might be interested in. Those are called Lewy briefs. And finally, you can watch Spark for free on Mediflix. I'm proud to tell you it's actually their most watched video of every video Mediflix hosts. Spark is actually the number one streamed video. We also have some educational resources we provide to the community as well as to professionals. We are going to have an online learning management system coming soon, but in the meantime, you can feel free to come to our website, take a look at any of the materials there, and you can order them, and we ship them out free of charge. So this never costs you anything. And sometimes they come directly from lbda.org, and sometimes they come from places like the NIH. So you can order this booklet, for example, through the National Institutes of Health website, nih.gov. One thing I want to point out about our educational, before we actually get to the continuing education here, is we talked this morning about the medical alert cards, and those went like hotcakes. You guys took the advice. I forget who it was who mentioned them. Was it you, Julie? Thank you, Julie. You guys took her advice, came and got this medical alert cards. Some of you may have come out and said, I don't see any medical alert cards. If that was the case for you, please pick up one of these booklets. It's called Facing Lewy Body Dementia Together. And in the back cover, there are 2 copies of the medical alert card that you can tear out. So we do still have many of these available at the table. You just have to find them in this booklet instead of on there. Okay, so tons of those. If you want to grab one, go grab it. You can also order those from our website. Again, anything on our website, we can ship out to you free of charge. We do offer some continuing education. I think this may be one of the things that's not free of charge because I believe it comes with CMEs or CEs, and these are really meant for professionals, for the community, and continuing education almost always has kind of a charge related to it. All right, other professional education that we're working on. We are adapting through our scientific community something called Diamond Lewy. And this is something that was put together actually in the United Kingdom by a bunch of dementia experts in the United Kingdom about how to diagnose Lewy body dementia, because we talked earlier about the diagnostic process being difficult and long, and many of you here in this room probably were misdiagnosed before you got your correct diagnosis. So part of this is diagnosis, and the other part of Diamond Lewy is clinical management. And this is really, this is meant for professionals. So the idea is to try to teach some of the doctors out there who are not yet as familiar with Lewy body dementia about Lewy body dementia and how to recognize it, what kind of medications to avoid so you don't end up taking Haldol like we talked about earlier. So this is an important part of what we do, ultimately for all of you folks, but doing it through the medical community. Research. Well, I'm the director of scientific initiatives. This is my favorite part to talk about. And the first, we're doing a lot here, but I think we're just going to highlight a couple of things in this talk. And the first one of those is our research centers of excellence. This is a network of 21 sites spread across the country, just in the US for now, but spread across the country, who focus on several things. One of them is increasing access to high quality care. We want to make sure that wherever you live, that you have access to people who are well trained and in Lewy body dementia and are going to provide you with high quality care. It's also for the purpose of establishing a clinical trials ready network. You folks live, I assume most of you are relatively close by, so you've got access to Dr. Merman and Dr. Rizzo and Julie and the team here, and they're running clinical trials like the Rewind LB study, but that's not the case everywhere. And so the idea for us was, let's try to find other areas as well and kind of lift them up and ensure that you have that everybody has access to this kind of care. And also increasing access to support groups. You're lucky enough to have a Lewy Body Dementia specific support group here, but that's not the case everywhere. And a lot of people with Lewy Body Dementia will go to Parkinson's disease support groups and have more or less success there, right? Some people with Lewy Body Dementia will use an Alzheimer's support group. And again, if you're the only person there with visual hallucinations, it might not be quite exactly what you're looking for. So the idea with the Research Centers of Excellence is that each of them has a Lewy Body Dementia specific support group. And we also ensure that all of the RCVs, the Research Centers of Excellence, do professional education, okay? To make sure that the people who don't live quite so close to these major university medical centers, that their physicians also have access to education about LBD. Now, this is something I would like you to write down, if you don't mind. This Lewy trial track. So like I said, you've heard here today, you have access to clinical trials here with a biomarker study using the magnetic, the MEG rather. You have access to Rewind LB here as well. But there are new studies that are coming online all the time. And it's also possible that you might be appropriate for one trial and not appropriate for another trial. But you don't also want to have to go to clinicaltrials.gov every week or to see, well, is there anything new? Is there anything new? Is there anything new? One of the things that you can do is sign up for Lewy Trial Tracker. This is from our website, lbda.org, and it's pretty simple. Basically, you fill out a questionnaire or a survey. You answer 15 or 20 questions. It's things like your demographics. How old are you? Where do you live? Then we also ask you things about, would you be willing to have a brain scan as part of a clinical trial? Would you be willing to take an experimental medication as part of a clinical trial? Things like this. How far might you be willing to travel if you live right next to a study site, etc. And then when we find new studies that have body dementia, what we do is we compare their inclusion and exclusion criteria. Those are the things, you have to be this age to get in. You can't have that medical condition. Those are called inclusion and exclusion criteria. So we compare your answers to the survey to the inclusion and exclusion criteria of the new studies. And if you're a fit, we're going to send you an email about that study. And then there's a web page rather on our site that lists all of the people that you can contact. Pardon me. Lists all the people that you can contact at the study site. We never share your information with researchers, okay? This is one way. You tell us a little bit about yourselves. That gives us an opportunity to tell you about the studies. And then if you're interested in the study, it's up to you then to reach out to the study team. And we give you their contact information, but we don't want you to be worried that we're going to share your information. We will not do that. So you can just go to lbda.org and search for Lewy Trial Track, and you'll find that. So what else are we doing in research? Well, there's some things on the slide here that may be a little sort of esoteric, but the idea here is an overview of the sense of the kind of things that we do. We convene researchers together to work on things like digital biomarkers. What does that mean? Well, that might mean things like, does your watch, which tells you about your activity, how much activity, how many steps you've taken, etc. Could we use that to potentially tell us something about where you are in the disease process, or whether you might be at risk for developing Lewy body dementia? We also meet with the FDA periodically to give input on clinical trials, trial design. And then, of course, we meet regularly with the National Institutes of Health and give them input as well. Oh, my timer is telling me I'm out of time. So I'm going to quickly finish this up. Working with pharmaceutical and biotech. I know that the pharmaceutical industry does not have a great reputation in this country. I understand that. But the fact is, when we're talking about drug development, that's who takes drugs through that process and gets new drugs to the clinic so that your doctor can prescribe them to you. So it's important to us to be working with them as well. We work in advocacy, including contributing to the national plan to address Alzheimer's disease and now supporting a national plan to end Parkinson's disease as well. In terms of support, this is Brandy Hackett, who heads up our support program. And you have the Lewy line here. And you can always find us at lbda.org as well. And feel free, please call, and please call early. You know, if you wait for a crisis, we will help, but it's much easier for us to help you, and more, you'll have a better outcome if you connect with us before a crisis. Lots of volunteer opportunities. I won't go through all of these here just because, like I said, I'm already out of time, but we do have lots of opportunities to get involved and help us out with our mission. So just a few things here. You can always participate in research, or at least consider participating in research. We have community fundraising events. Always takes money to make things happen. You guys all know that. Community event support. Lewy Buddies. I think Julie talked about Lewy Buddies earlier. Somebody. Lewy Buddies are folks that who either have Lewy Body Dementia or know someone who has, and can help you, on your sort of a peer support kind of a project there. So some key takeaways, we're committed to education, support, research. That's our goal. That's what we do. We talked a little bit about the Research Centers of Excellence Network, and it takes a village. So we do ask you, if you are so moved, please do join us with raising your voice, volunteering, however you might like to be involved. And I'm going to actually end there, only a few minutes over, I think. Thank you again to UNMC for inviting us out today to be part of this, and really for all of you guys for humoring me while I had my 15, now 20 minutes up on stage. And if you have any questions for me, feel free to reach out. My email address is here. It's very easy. kfargo, just my first initial, my last name, at lbda.org. Thank you very much.
Also, we will make Dr. Fargo and Dr. Goldman's slides available to everyone. So just make sure, Sally, you want email addresses or just people to tell you that they want the slides, or how do you want to do that? Okay. Okay. The UNMC conf. Okay. All right. So we'll get that information to you. So thank you, Dr. Fargo. So next up is Heartland Neurological Therapy and Wellness Center, who we partner with for our wellness and support group once a month. It's the third Monday of every month, and it has been an amazing program. And they have so graciously donated their time today to give you guys a little bit more of intellectual stimulation and some movements, right? All right. Thanks. So Sherry, Sean, and Amy.
Move the music first. Okay, hold on. I'm just gonna try to look this up. Oh, okay. And then, am I on? No. Okay. Okay, perfect. Thank you. All right. Well, hello, everybody. Good afternoon.
Welcome to the therapy portion of today. I just want to start out by introducing myself. My name is Shawn Frola, and I'm an occupational therapist at Heartland Neurological Therapy and Wellness Center. I've been an OT for over 25 years and love what I do. Today, I'm excited to be here because one of my favorite parts about being an OT is working on helping people to improve their quality of life. And that gets to be our topic. So, all right, so what is the role of occupational therapy? Let's see, occupational therapy can play a crucial role in enabling maximized quality of life for people with Lewy body dementia. OT can do this by addressing a number of areas, including physical and motor functioning, fine motor functioning, ADL function, and also looking at addressing cognitive, emotional, and visual perceptual needs. So let's talk about some key aspects in OT. Let's see, one area OT addresses is ADL function. So things like activities of daily living, including dressing, bathing, grooming, hygiene, eating. By focusing on ADL, OT aims to empower individuals to maintain or regain their ability to perform essential daily tasks independently or at their highest level of independence. This is so important because not only does performing at an optimal level of independence with daily routines enhance quality of life, but also promotes self-esteem, autonomy, and a sense of accomplishment. So, let's see. So what are some ways occupational therapy can go about enabling increased independence? In working with warriors, as Julie put it earlier, OT uses various strategies and adapted or modified ways to carry out exercise. So this needs to be based on people's individual specific needs due to fluctuating and varying cognitive and visual spatial limitations in order to enhance muscle strength, range of motion, flexibility, stability, and adapting exercise approaches that prioritize safety and encourage simplicity and technique according to someone's specific needs or challenges is important for carrying out exercises and obtaining the optimal benefits of exercise. Improved muscle strength and overall increased physical functioning can enable increased independence with ADL by enhancing range of motion or maybe even reducing fatigue. For example, increased upper body strength attained through modified exercises can help to promote increased ability to lift your arms or manage your shirt, maybe putting your arms into the sleeves of a shirt. So all of that helps with increasing ease and independence with tasks. Also, stronger fingers and wrists and increased dexterity can make it easier to manipulate small objects like buttons, zipper pulls, tying shoes, or grasping eating utensils, maybe even holding onto like a toothbrush. This can also aid in improving handwriting skills or increasing the ability to open lids or containers. And all of these can help to increase quality of life. Strength training can also improve core strength, balance, and postural stability, which are also important in promoting increased independence with self-care like dressing, reaching across your body, reaching down during lower body dressing, and can also provide a sense of security. So when you're managing pants or putting on shoes, for example, or even during bathing tasks. By improving strength and balance, not only is physical functioning promoted, but also confidence and overall quality of life are boosted and improved. Another way OT works to promote increased independence with ADLs is through adaptations and modifications. So adaptive or alternative clothing with features like Velcro closures or large buttons, easy pull-on clothing might make it easier for individuals with Lewy body dementia. So an example might be if I've been working on strengthening and fine motor coordination and dexterity training, and the person is still struggling managing like button or doing their zipper or pulling on pants. Looking at modifications or adapting the activity is an important step in promoting independence. Continued difficulty with clothing management could be due to a variety of symptoms associated with the LBD and could possibly be due to cognitive or visual spatial deficits instead of strength or dexterity. So trying to find alternatives or even types of clothing that will promote success and decrease stress is so important for increasing quality of life. So just even as simple as adapting the type of clothing the person is wearing or decreasing that part of the task that makes it complicated can be important to promoting quality of life and sense of autonomy. Let's see, home and okay. Some other examples might be looking at adaptive eating utensils with ergonomic grips or built-up handles, or possibly even adaptive cups to maximize independence with eating. Consideration of adaptive equipment such as a long-handled sponge maybe during bathing might help with reaching and keeping somebody more independent. Other adaptations may include the use of visual aids. So for example, possibly utilizing contrasting colors during meals, maybe placing dark foods on light plates and vice versa, light foods on dark plates, and increasing lighting during dressing and eating times can help with increasing independence. And another key aspect in OT treatment is to address home and environmental modification. Enhancing safety in the home is one of the most important interventions in fostering greater independence. So what types of things might we be looking at? It's important to make modifications such as removing tripping hazards, decreasing clutter, possibly installing grab bars, maybe removing mirrors out of a main living area, and using contrasting colors to improve navigation and reducing confusion. Creating a safer and more accessible living space might also involve rearranging furniture or installing ramps or even adding see, another aspect and my favorite part to address is the importance of engaging in meaningful and purposeful occupation. It is so important to assess a person's interests, past hobbies, and current abilities, and to understand what activities are personally meaningful to an individual. OTs aim to enhance an individual's sense of purpose, well-being, and overall quality of life. By combining environmental modification, skill building, such as muscle strengthening and balance training, and social engagement, all with consideration regarding specific needs and symptoms, individuals living with LBD may be better able to navigate the challenges of this condition and enjoy a higher quality of life. And lastly, another key aspect in OT treatment is incorporating education, support, and caregiver training. OT addresses this by providing education regarding ADL techniques and recommended adaptations, providing guidance on safety measures and fall prevention, and by providing education on recommended home modifications when indicated to create a safe and dementia-friendly environment for the person. Connecting caregivers with support groups, possible respite care services, and community resources can foster a network of support and benefit both the caregiver and the person living with LBD. Okay. All right, so for the last slide, let's take a look at some possible takeaways from today and look at some home and community keys to maximizing quality of life. Adapting and modifying the environment for someone living with LBD can significantly reduce frustration and create a supportive environment, even with the unique challenges of changing and fluctuating cognitive and motor symptoms. As we've addressed, I just want to reiterate the importance of optimizing safety in the home. Mobility aids, assistive devices such as grab bars or handrails can also facilitate greater independence and safety in the home environment. By creating a navigation-friendly space that reduces confusion and enhances independence is so important in maximizing quality of life. Maintaining dignity and independence. Receiving care that upholds dignity, promotes independence, and simplifies ADLs to the greatest extent possible, given abilities and challenges, is crucial for people with LBD. having a flexible, comfortable, and respectful environment, using validation techniques, and maintaining patience, as well as providing positive reinforcement, praise, and encouragement to motivate, are all vital in optimized quality of life. And then lastly, engaging in meaningful activities can provide a source of joy, reduce behavioral symptoms, and foster a connection with the person's identity and past experiences, even in the presence of cognitive decline associated with this disease. So in conclusion, OT can provide a holistic and person-centered approach to aim at enhancing an individual's overall well-being, maintain their dignity, and optimize their independence as they face these challenges. By addressing various aspects of the condition, occupational therapy can contribute significantly to improving an individual's quality of life and helping them live as independently and safely as possible while encouraging a continued sense of identity, purpose, and joy in their lives. So, all right, thank you for listening to me, and it's Sherry.
Okay. Thank you. Okay, how's that? We good? Hear me? Can you hear me? Hello, everyone. So nice to be here and see you all. Lots of friendly faces in the room. So good to see you. I am going to talk to you today about the role of physical therapy. So my name is Sherry Prince. I'm a physical therapist. I've been, oh gosh, a physical therapist for 24 years, I guess. Yikes. It's weird that I started so young when I was 5, but it happened, so it's okay. Anyway, so I've been at this for a little while, been working in the Parkinson's realm and LBD realm for probably about 15 years. So I don't ever know what to do with this, so I guess I'll just leave it there and hope I don't walk away from it. So anyway, I get the privilege of talking to you a little bit about physical therapy today. So physical therapy plays a significant role in maximizing quality of life for patients with Lewy body dementia by addressing motor functioning, mobility, safety, pain, fall reduction, and one thing that's not on the slide that I kind of added at the end is exercise prescription. And actually, probably we're going to talk about that quite a bit compared to some of even the other topics. So, okay, our key aspects of physical therapy is kind of small, so we'll go through it all though, so don't worry, you have it all. So first thing I want to say is physical therapy with Lewy body dementia looks very different for every person. So one of my favorite quotes, which I don't remember who I heard it from, which kind of was related to Parkinson's disease, but very similar with Lewy body dementia, is if you've seen or treated or met one person with Parkinson's disease, you've seen or treated or met one person with Parkinson's disease, right? Everyone presents differently, and Lewy body dementia is very much the same. So a physical therapy assessment will look different based on what your symptom structure is, what symptoms are most prevalent for you. So it's very, what we have to address on the physical therapy side is very variable, and it might look different from person to person. Some people with Lewy body dementia have very strong motor symptoms, as we kind of learned about this morning, and some have more predominant cognitive symptoms. So that changes what our plan of care looks like, and that changes how we need to treat that individual. So, but in general, there are definitely some key aspects or motor issues that are really important for a physical therapy to address. Kind of an overarching thing that I want to say about therapy today in general, and that would be PT, OT, or speech, is no matter when you're diagnosed, no matter how severe or potentially not severe your symptoms you feel like are, I would encourage you to have a therapy assessment so that you can get a baseline of where you are now, and that someone it's like another tool in your toolbox, another teammate on your team can help you kind of navigate this journey from that individual's perspective. So from the physical therapy perspective or occupational therapy or speech. So
First thing I want to talk a little bit about, and these aren't in any particular order because again, everybody presents differently, but gait. So physical therapy typically treats gait or walking. There's a lot of issues that happen. We get a lot of small steps, shuffling steps. Some people have a lot of problems with freezing or actually, not being able to continue with their movements, or kind of festination where you're kind of one part of your body is continuing to move, typically your upper body, while your feet are kind of frozen and stuck on the floor, and that kind of can lead to certainly a high risk for falls, not a fall. Gait speed, so that slowness of movement is very affected. And so we look at ways that we can increase your gait speed. There's a lot of studies out there that says if we can get your gait speed to be more normal, you are at this decreased risk for falls. So we want to work on increasing your gait speed safely. And then the need for assistive device. This is a really tricky one, and I would always suggest that you navigate that with a physical therapist. Sometimes assistive devices, when we fall or when we start to have balance issues, the typical standard is, go get a cane, go get a walker, go get something to help support you. Sometimes that's exactly the answer. Sometimes in Parkinson's and in Lewy body dementia, an assistive device of a certain kind can actually make your walking worse. It can make your festination worse. It can make your posture worse, which then makes your gait worse. So again, lots of room for assistive devices in this realm, but I want you to have somebody that is helping you assess what's the most appropriate for you. So that's one thing physical therapy can do. Balance deficits, postural instability, like Sean mentioned, we typically see, a decreased space of support, definitely decreased reaction times, which just puts us all at really increased risk for falls, right? If we are not reacting as quickly, we can't react to a loss of balance as quickly, and we tend to get increased risk for falls because of that. So impaired posture, this is kind of, if I should have put that in bold letters here for Lewy body dementia, we tend to see lots of impaired posture. When we start to have more of the forward flexed posture or even leaning posture, that changes our center of gravity. Our center of gravity then shifts and it changes how we walk. We have a lot more trouble being able to achieve normal gait. You know how I talked about gait speed, and gait path becomes changed. So as we become more forward or maybe even lean, it's a lot harder. If you ever try this, it's a lot harder to advance your legs the right way. It's a lot harder to hit your heels. If you don't hit your heels first, you won't hit your toes first. If you don't hit your next, and if you don't hit your toes, you can't kick with a really good step to the next step. So lots of things. Posture is not just about standing up straight. Posture affects your gait, it affects your balance. So posture is a huge thing that we need to work on in both Parkinson's and Lewy body. So certainly there's a place for strengthening, like Sean mentioned, straight up lower extremity and core strengthening. I find actually more that people come to me saying they're weak, and it's not necessarily a muscular weakness, it's a muscular recruitment. We're not using the muscles in the right way because of the rigidity and tightness that we had. We certainly see weakness because of decreased activity and things like that, but sometimes we're just not getting those muscles activated in the right way, so we fatigue quicker. Again, if any of us try to walk for very long like this, you're going to feel very weak very quick. Does that necessarily mean those muscles are all weak? Maybe not. Maybe we just need to get you using them and activating them in the right way. Decreased endurance, decreased activity tolerance, and then of course we tend to see this lack of reciprocal movement, which is actually very important for your balance. And so working on all of those things are really important. Kind of 4 primary areas, that's not on the slide, this is just my little add-on. 4 primary areas that become difficult are anti-gravity extension, so posture, right? Being able to stand up against gravity. Very important that we work on that. Probably #1 thing we need to do. You're going to get to work on it when we move here in a little bit. Weight shifting, being able to shift your weight side to side and from bottom to top. That's why transfers get hard. Walking gets difficult because it's difficult for you to shift your weight side to side and from different parts of your body. Rolling in bed, so shifting all of your weight from one side to the other side to be able to roll, those things become difficult. Rotation. Parkinson's and Lewy body dementia wants us to get small and tight and stay in one plane of movement. All of those things are very bad for your balance. So we need to be able to get big. We need to be able to move in all sorts of planes of movement, to be able to use all the muscles that we have, walk in a normal way, and decrease our risk for fall. And then transitional movements. We have to work on getting bigger movements. So bigger steps, bigger arms, bigger everything. So that's kind of the things that we're going to work on. For Lewy body dementia, honestly, we work a lot on true Parkinson's movement techniques. So Parkinson's wellness recovery, those exercises are very important. We're going to talk at kind of, when we all three get done talking, we're going to talk a little bit about some unique things about therapy with persons with Lewy body. And so the issues are the same on the motor side, but we might have to tweak how we work on them a little bit because of the visual spatial deficit. But those Parkinson's specific exercises are still very important for you. Okay, well, I'm sure I'm over. You guys are gonna have to give me just kick me off the stage, basically. Okay, so research, and this is not a research topic situation, but I want to explain to you a little bit about, we know that exercise is well researched. We know the benefits of exercise, okay? So we know that it improves our heart-lung function, which then improves our motor function and our attention and cognitive function. All of those things are well researched in exercise. Exercising improves your attention. It activates your brain. It improves your ability to plan things. So today, when we do our movement demonstration, you're going to see that you have to do a couple movements in order, right? That's difficult when you're first learning it, but the more you do it, the easier it gets. So as you exercise in certain ways, it does get easier, and it helps your brain learn how to move correctly, which is the purpose of our therapy and our exercise, okay? Exercise also has been proven to improve memory in older adults, and balance, of course. Exercise in Parkinson's is very well researched as well. So we're going to talk about that in a minute. But then exercise specifically to Lewy body dementia has not been researched as much. We're working on it. There is a study out called the PRIDE study, which is promoting independence in Lewy body disease through exercise. And they did look at specific kinds of exercise related to Lewy body, including balance training, functional training, and progressive resistive exercises. And there was an improvement in function. So we have to just kind of start to continue that research, right, to show what we need to do to exercise in the right way. All right, this next slide is kind of sciencey, kind of confusing and really small print, so I apologize for that, but I'm going to kind of sum it up for you. So at the top, it basically says that exercise, I can't even read it, exercise, so when you complete goal-based exercise, and we're going to talk about this in a minute on my next slide, couple things, goal-based exercise and aerobic exercise. Those two things, when you do those two things, we get a lot of good brain things happening. So you'll see that brain thing, right? We improve activity of the brain. We improve the trophic factors. We improve your blood flow to your brain, all those things that are very important. And we also improve the synaptic connection. So how well your brain communicates with the rest of your body. That's improved when we exercise, okay? When you get that improved, those two things combined basically make the circuitry in your brain work better. And when that happens, we see better outcomes. And the better outcomes are improved motor movement and improved cognition and improved attention and improved mood, right? You're going to see when we do our exercise demo in a minute, your mood's going to improve. Now, it might be laughter at us up here, but it is still going to be an improvement in your mood. So brain health and neuroprotection. So we want to maintain and improve cognition if we can. We want to promote independence and mobility. Exercise also improves sleep, right? We know from this morning that there's a lot of sleep issues in LBD. So if we can do something like exercise that's going to improve your ability to sleep, we want to do that. And of course, decrease your risk for fall. So I've heard 100 times over the years that as long as you exercise, it doesn't matter what you do. I mean, I like the message behind it. I like the fact that we're encouraging movement, but that is actually not exactly true. It does matter what you do, and it does matter how you exercise in Parkinson's and in Lewy body. So the theory of whatever exercise you'll do is what you should do is true. You want to do exercise you enjoy. So if you like boxing, you should box. because there's an emotional engagement to that. If you like dance, you should dance, that's true. But we should exercise in a certain way. And there's 4 things that we need to do when we exercise. So we're trying to get neuroplasticity, or that from the slide before that, change in how your brain's working, right? And so these are the 4 things we need. Your exercise program needs to include these things. High physical effort. Lots of research out there that shows you have to work harder than you would self-select to do. So all of us, whether we have Parkinson's or Lewy body dementia, if we research how hard we would typically self-select to work, sorry about that, our heart rate would be around our 60% range of our max heart rate. That's been pretty well documented, that if we all get on a treadmill and we say, oh gosh, we're working pretty hard, I feel hard, I don't really want to go any faster, and we looked at your heart rate, it would be about 60% of your max heart rate. And the research actually shows that in order to see this brain change, this neuroplastic effect that we can get from exercise, we need to be more between the 75 and 80% of our max heart rate range, okay? So that's another reason why you need to see a physical therapist, occupational therapist that can help you direct how to safely get that rate, right? Because you can't just go do that today. If you haven't been doing it, you can't just go hop on a treadmill, get your heart rate to 80% of your max for the next hour and be good. That's not how it works, right? We have to work in intervals and get you there. So you need help with that. But it's important that you work harder than what you would self-select to do. Attentional focus, and this is an issue we're going to talk about with the difficulty or kind of the unique challenges with LBD, is that we need to have exercise that makes us attend to how our body is moving. So part of the reason we have postural impairment in Lewy body is because your brain is not sending you correct signal. So if you knew that you and your body was giving you the right input, you wouldn't probably have forward flex posture, because your brain would be telling you, hey, I need to stand up straight. But that's that impaired message that you're not getting. The person with Lewy body is not getting that message correctly. And so we need to do exercises that make you pay attention to what your body is doing. Increase the attentional focus that we tend to lose in Parkinson's and Lewy body dementia. So we're going to work on attending to what our body is doing. So when we're doing movements and we're exercising, I'm going to say, okay, is that as big as your arms can move? Is that as tall as you can stand? Are your shoulders back as far as they can go? So that you have to think, well, no, actually, I can move my arms even bigger. And that's training your brain to give you better messages than the incorrect ones that you're getting, okay? Cognitive engagement. We need you to be using your brain while you're exercising. So we need you to be activating your brain and thinking while you do it. And sometimes I give, which this gives bicep curls a bad rap, but I give the example of, if you're just doing bicep curls, that's not a complex exercise, right? You're just bending and straightening elbows. You don't maybe have to think about it. After you do a couple, you could just doing this, and it wouldn't be very complex. So the exercises that we're trying to get you to do are probably more complex than that. When we do some exercises, we're going to say, okay, when you do this exercise, this is where your eyes should be, where your head should be, where your shoulders should be, where your neck should be, where your arms, where your legs. So you have to think, okay, do I have all of those things happening? And it makes your brain activate, and it's shown to improve neuroplasticity, which is our goal. And then emotional engagement. This is the piece where go do whatever kind of exercise you want comes in, right? So that part is true. This is that piece. We want you to be engaged in your exercise. We want you to have fun. We want there to be whatever interests you, because then you're emotionally engaged in it. You can also get emotional engagement by exercising in a group. A lot of people like to go to a group to exercise because they know their friends are going to be there and they're going to be exercising, and maybe they have a great exercise instructor that they really like that makes them laugh, and whatever. All those things cause emotional engagement, which is actually very good for neuroplasticity. Okay, so our key take homes for you: maximizing quality of life. I think some of the things that are the hardest for folks is we want to constantly remind our persons as caregivers, our persons with Lewy body dementia, of all the things that would make them better, because we care about them, right? So because we care about them, we want them to take bigger steps. We want them to stand up tall. So we tend to over cue, and we know from this morning that there's this slower processing. So it turns into something like this, like take big steps, stand up tall, make sure you stay close to your walker, all like rapid fire. And unfortunately, because of that slower processing, because of Lewy body dementia and Parkinson's, that processing speed, we're way back on take big steps. Like in our brain, we're still trying to take a big step, and now we've had 6 other instructions in the meantime. So if you're looking at the way you can take the information from physical therapy and maximize the quality of life at home, I would say less cues, simple cues, big steps. If somebody's frozen, big step, kick your foot, something like, and then stop and let that happen. Though that's a key take home. It decreases your frustration as a caregiver. It decreases their frustration for the constant kind of what some people would lovingly call as nagging, right? So it's a quality of life improver for both of you, okay? And learn what those cues are from your physical therapist. So again, really a reason why you need to work with a physical therapist is because you need to learn the cues that work, because the same cues don't work for every patient, okay? So something might work really well for one person, not the other. So you need to learn what works good for your person. Exercise, help promote something consistent that will be fun to do and kind of meet those guidelines. So there's lots of different examples up here of exercise, bikes, treadmill, group classes, boxing. Find something that works well, that fits those neuroplastic criteria that are on the slide before, right? And then help your loved ones stay consistent with those. And that might mean you have to exercise with them, right? That might be that emotional engagement is that you both go, okay? Apathy, I want to say just a minute about apathy, and then I think I'm over my time by a ways. So this apathy or lack of motivation, this not wanting to exercise. I think, in our experience when we work with caregivers, and that's probably one of the biggest areas of frustration is that you, as a great caregiver, I'm going to get you signed up for physical therapy. I'm going to get you signed up for these exercise classes, and you're going to go, and it's going to be great. And then you get to the time that it's to go, and your loved one doesn't want to go. And you, as the person with Lewy body or with Parkinson's, don't want to go, even though somebody told you that it's going to help. And that, I like to put that where it belongs, which is, it is a symptom. It is apathy and lack of motivation is a symptom of Parkinson's disease and Lewy body dementia. So when we kind of put it in that category of where it belongs, there's not near as much shame to it, right? Like if your loved one has a bad tremor, you as a caregiver wouldn't be like, stop tremoring. Like, I don't want you to tremor. So you would be like, well, that's a symptom of their Parkinson's disease or their Lewy body dementia. So you understand that. But when we get to kind of some of these non-motor symptoms that really affect exercise and really affect therapy, like apathy and lack of motivation, it's a lot harder to say that, right? But if we kind of put it where it belongs, not saying we don't have to deal with it. We have to overcome it because we know exercise is the only thing that's going to help us, kind of change our progression and how we manage this disease. Then we have to we have to give it credit, but we can't let it override us, okay? And it can't get to be that personal thing. 80% of people with Lewy body dementia experience apathy. So it's a lot. Okay. Sorry, Amy, I probably went over your time. We're going to go on to speech.
Hi, I'm Amy. I'm with speech therapy. It is possible it could be a little bit of a sleepy time for you, but it's possible there might be something really good that I say that you wouldn't want to miss. I'll try to shorten mine up a little bit. Speech therapists help with speech production, so actually the sounds and the production of speech. We help with the communication process, cognitive linguistic things, just the whole process of communicating, and also with swallowing safety. Thank you. Key aspects, as we've heard today, everybody's journey is different. I picked out just a few key aspects that we see often in the realm of speech. And the first one is attention. We've heard that many times today, but I wanted to spend just a couple of minutes talking about attention. So that is, distractibility. That's when things are much easier to become distracted. That's when it's harder to stay focused. It's harder to pay attention. There's so many different kinds of attention and levels of attention, but some of them are external, like environmental. So what I mean by that is television going on, right? So that's a distraction. Maybe it's the dog barking, and every time a leaf blows across through the window, the dog is barking. Why does every time? And so something like that can really distract someone because it's harder to block it out, right? It's harder to not hear it and keep focusing and paying attention on what really is right in front of them. Also, attention can be what I say kind of between the ears. Right, so this is something every single one of us in this room is guilty of. You can be talking with someone, you're having a nice conversation, you're talking back and forth, and they're looking right at you, you're looking right at them, but you're actually thinking about what you have to get at the store. Because after you leave here, you have somebody coming and you're busy and you're distracted and you're smiling so politely and they think you're listening, but you're really kind of not. Well, actually, not at all, because you're worried about what you need to get at the store. So attention is many different things. Sometimes it's external, sometimes it's not. I was just going to share with you an analogy that I learned in graduate school. I honestly think it's the only thing I remember from graduate school, but it must have been good. I'm going to tell you about it. We used to talk about a principle called the shutter principle. And it was in relationship to a camera shutter. So, either the shutter's open or it's closed. It's open or it's closed. So if you're having a conversation with somebody and you're playing a game of tennis with them, so you say something to them, process that information, hit the ball back to you, and this is just this nice game of going back and forth. If, though, someone says something to me and they hit the ball to me and my shutter is closed, the words just kind of bounce off. They hit the shutter and they bounce off. So the words never really did go in. They didn't even get in to process and turn around for me to come back and reply to that. If my shutter's open, right, if it's wide open, hit the ball, comes right to me, it processes, I understood what they said, I comprehended that, I answered them back, and there was a complete full circle exchange that happened. A lot of times with attention, shutters closed. So it's different than memory because it didn't get all the way in to forget it, right? It just never even got in. We sort of live in a world where people's shutters are closed a lot, right? People are on their phones, they're multitasking, and some people think they're really good at that. And actually the information isn't getting in. I mean, I'm number one guilty of that, right? I think I'm doing all these things in the kitchen, someone's asking me something, but my shutter's not really open, it's closed. So I just share that with you to think a little bit about that because we do see that certainly with Lewy body dementia. Executive functioning. So you might be quite familiar with that term. That is really following through and carrying through with a complex activity that has lots of steps. That is difficulty with organizing and planning. So an example of that, I would say it's kind of like if you're making lasagna at home. You have to preheat the oven. You'll be browning your meat. At the same time, you're going to work on your sauce. And then you've got to get the ricotta out of the refrigerator because you don't want to spend all day long doing it. You want to kind of time it and do little pieces and parts kind of all at the same time so you can get it assembled and get on with your day. But that becomes harder, that organizing and planning and timing of things and understanding how to sequence those steps, that part gets harder. When executive functioning becomes challenging, that really affects independence and safety. That affects that being able to be safe at home and independent. Single tasks are usually better for that reason. Judgment can certainly be affected because judgment requires processing, comprehending, remembering, right? So we can see how that could be affected. Word finding. I put that one in there because that's exactly what that is. It's having trouble finding the word that you want to use in the timing that you want to use it. So not 2 o'clock in the morning when the word pops into your head and you're in bed, right? But in the timing that you want to use it, that you can grab and use that word. And just so that we can all kind of understand this, everyone's been in this situation. Let's say you're in a social situation, maybe like today. You see a couple approaching you and you're thinking, oh my gosh, I don't know her name. What is her name? And you kind of start panicking and you tell your partner, don't ask me to introduce you because I'm. And so you're kind of stressing out about it, and she's barreling right towards you because she knows your name, and she's coming and she approaches right away and introduces you to her partner. And so as you're sitting there, you're nervous about that. So it affects your communication. It affects your confidence in the communication. So you kind of feel like you're going to get outed. Like she's going to get it eventually that I don't know, that I can't think of her name, that I'm not introducing her. And you're hoping that your spouse with you is going to step up and say, hi, I'm Amy, I'm happy to meet you. And so that little feeling right there is a little bit of what that feels like when you cannot think of the word that you want to say. And people, it's easy to communicate less, right? It's easy to pull back and not be as willing to participate when there's a lack of confidence. Memory can certainly be affected, and memory affects everything. Fatigue affects everything, and memory affects everything. Okay, speech production. So we were talking about this earlier in a conversation today. Sometimes we'll see the volume of speech lower. So if that happens, you hear that volume go down. Sometimes the quality of the voice, you hear it sound hoarse or gravelly, or it'll change. It's just not the same sound in the voice anymore. Sometimes we will hear, or like the intelligibility will go down. So it's kind of sounds like mumbling. It's harder to understand. And in many of these cases, there are excellent evidence-based programs that can help with that. We can do exercises, make that voice stronger. We can make the speech stronger, and we can certainly focus on forward projection of the speech to get that volume up and get that confidence back in the sound of the voice and the speech. I would say too, with that, it not only strengthens the muscles for speech, but it strengthens the muscles for swallowing. We use many of those same muscles for both of those things, and it's very, very advantageous to do that and to pursue that. Swallowing rehab. So with swallowing, this can be a little bit of trouble with eating solid foods, with drink, maybe with pills, and sometimes with your own saliva. So this is if you're coughing a little bit on that, lots of throat clearing, maybe some choking happening. You need to get an evaluation. There are a couple of different ways for formal evaluation, and that would depend on, the therapist that you're working with, what they would recommend you to do for an eval. They may suggest to change the texture of the food or change the texture of the drink. They'll have lots and lots of tips and tricks that make things easier and safer. They may suggest to think about the environment that you're eating in. And, I think if we think back about that attention thing again, when it's a really busy environment and there's a lot going on and the TV's blaring, and the leaves blowing by, so the dog is barking, and then you've got some littles and wonderful people all around, and it's busy. People choke more. They just do. It's harder. Sometimes you need to quiet the environment while you're eating and just focus on the eating. Sometimes with people, I'll say, just turn the TV off totally and maybe just don't even talk. Just eat and just really keep the focus on the eating. The intake's usually better. And then secondly, the problems with the swallowing can really decrease. So for all of the things I've talked about, there are therapy ideas, techniques, and there's treatment for things, for all of these things. The one thing I would say is it is entirely more beneficial if a care partner or a family member attends at least a couple of those sessions to understand what it is that we're working on and to understand the compensations, to understand how to help at home. I just think that makes a great big difference. Communication tips. So when communication gets smaller, worlds get smaller, right? That just starts to happen that way. It's very important to try to simplify, but also to stay engaged. Improving communication inevitably improves quality of life for everybody. Frustration goes down for everybody when communication is better. Using a calm presence and a calm tone is very important. Sometimes with Lewy body dementia, things can go sideways and they can do that relatively quickly. If you're able to keep a calm presence and a calm tone, everything's going to be okay. Everything is going to be okay. And it helps support that emotional regulation as well. Reducing background noise. Always think about the attention. Think about the camera shutter. Think about when it's easier for the shutter to be open is when there's a little less noise. A lot of times we'll hear people say, speech pathologists will say, simplify your language or give a binary choice. And then I think, do people really know what that means? When I was thinking about this, I thought, okay, so let's suppose that you're the care partner and you're looking in the fridge, you're figuring out what you're going to eat. So you open up the fridge and you're kind of talking to yourself or talking to each other, and you're well, we have pizza, we could eat pizza. Well, you know what? We should eat the hamburger that we had last night because we need to use that up. Well, we don't have any buns. Don't have any buns. Let's not have a hamburger. We could have spaghetti. If we have spaghetti, we could actually use the hamburger from last night, use it, even though we don't have any buns. We could do that. What do you want? If I'm looking around this room, nobody even knows what the options are. It's like, I don't even know what you just said. So with simplifying would be pizza or spaghetti. People can get lost in all of the words, and that just kind of complicates things. And we don't realize we do it because we do that. We narrate what we do sometimes. Oh, I'm gonna catch up. But really what can happen is that people just kind of get lost in that. So I just share that with you as kind of an awareness of how to simplify. Ask for or make eye contact. This is an important tip, right? So if you want to try to plan for somebody's shutter to be open, I think reduce the background noise, but also sometimes a simple touch on the shoulder, like a simple touch or to say their name first, right? Like Todd, like if my husband's watching football and I'm going to the store, I need to say, Todd, I'm going to the store. Gonna be back in an hour. But it's true. If you say, if you have their attention first, everybody's shutters open and everybody is, understanding and everybody's together on the communication. Let's see. Yeah. Well, yeah. Because what it usually is at home, and let's just be real, somebody's head's in the dishwasher and the other person's in the other room and they're sitting in the easy chair watching television and nobody's shutters are open, but you're kind of hearing each other's voice in the distance. You're not really making words out of what they're saying, but and then lastly is to allow that extra processing time. I think we've heard that a lot today, but a little pause time. because the processing, sometimes the words are processing pretty darn good. They just take longer than they used to. You have to get comfortable with just a little extra time. Yes, so thank you, and may you plan to communicate when your shutters are open. Now, here's the thing. Oh, we aren't done. Goodness, we're almost cutting us off.
We are close to done. Okay, so we just wanted to run through some unique issues related to therapy and LBD. That might be different than if you've gone to physical therapy for something else, okay? So skilled therapy services, so that is one-on-one therapy with a physical therapist, occupational therapist, or speech therapist, may be needed for longer, okay, due to difficulty with traditional post-therapy exercise. So typically, like if you or I had sprained our ankle and we went to physical therapy, they might see us twice a week for 4 weeks, send us home with a home exercise program, and a good luck, right? So that doesn't really work. Our post-therapy options for exercise, sometimes in Parkinson's and LBD, are not as successful. So because of all the communication things that Amy talked about and all the visual spatial things that we talked about, a group class of just a regular group class at the YMCA or just a home exercise handout. You know, if you're in the 80% with apathy and I give you a home exercise handout, that is not going to probably work. So we might need therapy for a little longer to really establish a good way to exercise. And the truth is it may be a continual therapy. It may be you're in therapy for a long time and then you maybe have a little time out and then maybe you're back in for a little while and then maybe you're out. And the therapist's role is to help you establish what you're going to do when you're not in therapy to maintain the exercise level that we know is needed. So that, you know, when you go seek therapy services, you should tell them that you assume that they are going to help you figure out how you're going to exercise post-therapy, okay? Because that should be an expectation of you when you go to therapy. You should know what you're going to do when you get done with therapy, right? That's the whole purpose. Medicare will pay for therapy to prevent decline. So, you know, Medicare changes all the time. We know that. But really, honestly, in the last few years, they have established really good rules that says if we can prove that we're preventing a decline, we can continue to see you for therapy. And so there are still people out there in the therapy world that, you know, maybe aren't as aware of that. So they'll say, well, I only get to see you for 8 visits and then Medicare won't pay anymore. It's actually not true. So you need to seek care with people that know how to access Medicare for persons with neurological conditions. And that's an okay thing to ask. You know, a lot of times if you go to the doctor, they're going to give you a list of places to go to therapy, and you should call them and interview them and say, do you have therapists that have experience with neurological conditions? I have this. It does not make sense for you to go to a sports medicine clinic. That's the reality. Just like I don't want someone with a torn ACL to come see me for their own benefit. Like if they want to get back to, you know, college sports, they should not come see me because I'm probably not going to help them very much. So, you know, one size does not fit all. You need to seek care for yourself and your loved ones that is appropriate to you. And knowing those Medicare guidelines is important. Visual spatial limitations require adapted ways to carry out exercise. So this I bring up because group exercise is so if you go to the YMCA, and I'm not listing on the YMCA, I'm talking about group classes anywhere. If you think about how they're instructed, they are very much instructed in a visual spatial way. So we're going to step 3 steps to the right, and we're going to go 3 steps to the left, and we're going to use our right hand to do this and our left hand to do this. And those are the things that become a little more difficult. That and the rapid pace and the dual task and many things going on around you in a group class, even people moving around you are a distraction. So group classes are sometimes difficult. I'm not saying inappropriate. We do them. So that's what we do. But making sure that you're finding one that is adapted and can meet you at the needs and maybe leveled with where you're at is important. Sensory awareness impairment. So that's what I talked about how, you know, you don't always know what happens happening with your body. So you don't always know you're forward flexed. You don't always know that your steps are small. You don't always know that your voice is small. You don't always know lots of things. Lots of things. So you need to be in a place for therapy and exercise where they are giving you feedback, right? So, hey, I think you can move those arms a little bigger. I think you can straighten those elbows all the way out. I think you can get that head all the way up. Those feedback things are important. So you should be in a place where they're providing feedback for you. Autonomic dysfunction, we talked about that this morning. There can be some safety issues. So if you have a lot of autonomic symptoms and lowered blood pressures, you need to be making sure you're in a place exercising with people that have experience with that so that you can be kept safe. And then just being aware that some of the things that Dr. Merman talked about this morning, not being able to maybe be on a higher dose of dopamine because of some of the hallucinations and things, our mobility might be affected. Our speed of movement might be affected because we're not really able to have as much dopamine that maybe may make us move a little better. So just having an understanding that, we may not be able to get to that optimal speed that we all wish we could be at, and adapting that and being understanding of that. So those are kind of some unique things. And like I said, if I could say anything, it's, just making sure that the therapists that you're working with have an understanding of kind of how to treat. And there's no perfect answers. Nobody has all the answers. But if you're working with folks that have neurologic experience, that's going to be helpful for you.
Being flexible, I think, is really important to remember. What worked yesterday might not work today, right? You have to just really try to be as flexible with fluctuations and changes and go with them. Focus on what is going well. In the way of, I think education and as a care partner, if you're a care partner and if things go a little sideways, I think something to think in your mind is, this isn't Todd, this is the disease, right? This isn't Todd, this is the Lewy body dementia. If you're a person that has a diagnosis of Lewy body dementia, I think you can say this, that's not me, that was the Lewy body dementia. Thank you for having us and listening to us for all this time. We're going to invite you now to stand up. We're going to do just a little bit of movement. Time for a stretch. So stand up, and then that's what we're going to do.
Hey, Dawn.
Too. We can choose shorter.
Yeah, let's do that.
Want to do
Wanna
that?
do that first?
Sure. Okay, yeah, I
Should we do
can,
that?
yeah.
Okay, and we're gonna do some more.
Yeah. Okay, so I'm
Okay.
gonna go first. That might still on. Oh, that one I don't know.
Okay. Oh, is that working? Oh, yep, sure is. Okay, so we went over a little bit on our time, so we're feeling bad about that. So we're gonna just do I think we had 3 songs, but we're gonna try and do 2, just to kind of move this along so we don't take any more time. So everybody get ready, right? Sean's gonna lead us in this first one, right?
Yeah.
And I'm gonna demonstrate a seated version over here, and then we're just gonna have lots of fun. Okay.
By the way, Sherry and Amy came up with these moves. Right.
And why? No, good job. Okay. Whatever. We did a little boxing. It was a big hit. We're gonna do it again. For those of you that know Georgie, I'm no Georgie, so but we're just gonna do the best we can with a little boxing. So remember, the purpose of this is to move big and have fun, and you can sing and you can, remember emotional engagement. All right, here we go.
All
Are
right.
we ready?
We're ready.
All right. We're gonna start with just following the music here first, all right? Hands up, protect your face when you're boxing, right? Bring those elbows all the way. Good.
Oh, I got a text. Oh, maybe the thing went dead. Well, I think it was a good one. One right ended early. It actually wasn't my fault.
But hopefully you guys get the idea that, you can move but have fun and then you do really important movements, right? We did a lot of weight shifting, rotation, extension. There's a lot of good things you can do with exercise and still have fun. It doesn't have to be just straight up exercise. So, all right, thank you. And we apologize. I apologize for going over. Really my fault.
Oh, yeah.
Okay, that was wonderful. Man, we got some dancers in here. I didn't realize you guys had so much rhythm. Wow, impressive, impressive. Thank you, Heartland Neurological and Wellness. That was absolutely amazing, absolutely amazing. All right, well, we have winding down to the end of the day, and we're going to go ahead with our keynote speaker now. Dr. Jennifer Goldman, MD, MS, is a fellowship-trained movement disorders neurologist with certification in behavioral neurology and neuropsychiatry. Dr. Goldman is an internationally recognized clinician, researcher, and educator who has focused her career on the non-motor and neuropsychiatric aspects of Parkinson's disease, Lewy body dementia, and other movement disorders, improving treatments and outcomes, and implementing innovative multidisciplinary care models. She graduated from Princeton University, received her MD from Northwestern University, and completed her neurology residency at Washington University in St. Louis, and movement disorder fellowship and MS in clinical research at Rush University. She has held numerous leadership roles in national and international organizations and is currently the Secretary-elect for the International Parkinson's and Movement Disorder Society and chair of the Lewy Body Dementia Association Scientific Advisory Council and LBDA Industry Advisory Council. Welcome, Dr. Goldman. I'm also good at spilling water.
Can you all hear me? Good, both sides, good, online, everyone? Great, well, thank you so much for inviting me to be here today. It's wonderful to come to Omaha from Chicago and delighted to hear everything that's going on and all the exciting work in what you're doing for Lewy body dementia here. So thank you very much to Julie Pavelka and Daniel invitation, and really congratulations on your inaugural initiative. So thrilled to be part of it. So I was given the task of talking about Lewy body dementia in 2023 and beyond. So I'm very excited about what we have in store in the future. These are really exciting times in neurology and neuroscience and everything we're learning about the brain and biology, and hopefully translating that into new therapies, therapeutics, and care so it reaches all the people in the community. And got it. Now I know not to touch that because it's going to do the same thing up on the screen. Okay, good to know. Let me get it back where it was. Okay, so these are my disclosures. I've received grant research support in the field to conduct research studies and honorary from organizations to help with advocacy and teaching and help consult to make trials in therapies better in the future. As we heard this morning, most of the medications that we use in treating Lewy body dementia are not approved by the FDA, but we draw from the general public and Parkinson's and Alzheimer's. So I'll talk about some what we call off-label medications and need to put that out there. And then, as Julie said, I have been very active in the LBDA world and field over past 20 plus years. So. Okay. What did I do here? What did I do? Did I break this? There we go. Okay, thank you. All right. technology. Good. So this is my magic crystal ball. I'm going to talk about some things that are happening currently, but also just some thoughts and insights I have about where the field may be going, and based on science that we know today. But as a disclosure, I reserve the right, since I can't predict the future any better than probably anyone else in this room. Some of these may come to fruition, and other of these may not. So, but we will look for the path forward. Okay. So this is what we're going to talk about today. I'll talk a little bit about some of the symptoms, recognition, and diagnosis, some of what we're learning about the causes and contributions to Lewy body dementia, a little bit of some challenges we have with the naming, as you heard about, this confusion, this soup of terminology, what's new in clinical trials, advocacy and engagement, and some concluding thoughts. Okay. So to start off on symptoms, recognition, and diagnosis, and I'm not going to reiterate everything that you heard from Dr. Merman this morning, but since repetition is key to our learning and education, you'll hear a few things that he may have highlighted. So, we talk about this terminology, and I actually think understanding the vocabulary as it is today is really important. It helps us speak the same language. It helps us talk to healthcare providers. It helps healthcare providers talk amongst themselves. But so there's some key areas that I think are sources of confusion. So just to set some of these definitions as well. So when we talk about Lewy body dementia, we talk about the clinical features, and that's that umbrella that you've seen in a couple different iterations that includes both Parkinson's disease dementia and dementia with Lewy bodies. You already saw the picture of the neuropathologist, Lewy, the Lewy bodies are named. But when we talk about Lewy body disease, we're really speaking about the pathology. So what we see under the microscope. So not so much the person in front of us, but what we see when we look at tissues or brain autopsy when someone's passed away, or biomarkers in the blood or spinal fluid that I'll talk about later. So we're looking for those pathologic clues that demonstrate changes in what are called Lewy bodies or Lewy neurites or neuronal loss. So you can see that picture on the very bottom is a microscope view of what a Lewy body looks like. I'm going to talk a little bit about a protein called synuclein or alpha-synuclein that we have in our brains, but has abnormality in its structure and what we call clumping or aggregates within Lewy body disease and Lewy body dementia. So I just want to make sure we're all on the same page of knowing that Lewy bodies themselves can contain aggregates or clumps of this particular protein called synuclein. And I think one of the unfortunate things is they're both called LBD, so that's yet another source of confusion in our acronyms. Okay. So we talked this morning about dementia, and one way to think about some of this is, what is the continuum? So at some point we are all aging as we speak, but what is the pathway from normal aging to something called mild cognitive impairment, which then may progress into a more severe or having greater impact syndrome called dementia. And this is also an important area because as we try to look at ways to slow down or reverse or ultimately prevent dementia, we need to think about what are those earliest stages. So you'll hear some of these themes coming up as I go through my talk. So these are the actual criteria that clinicians use to diagnose someone with Parkinson's disease dementia on the left, and on the right side, dementia with Lewy bodies. And I've been fortunate to be involved in both of these efforts over the years. The Parkinson's disease dementia criteria came about really to differentiate dementia, which is an impairment in our cognitive abilities that's sufficient enough to impact everyday life and activities and involving more than one cognitive area. So this came about in Parkinson's really to differentiate it from Alzheimer's. to recognize that, wait, these are both syndromes where there are cognitive changes, but they're different. So we know that not all Alzheimer's, not all dementia is Alzheimer's, and we know that Parkinson's dementia, dementia with Lewy bodies, both under the LBD framework, are different from Alzheimer's. They may have some similarities, but they are different entities, and that's where I think criteria can be helpful, as well as advocacy efforts like the LBDA and other LBD organizations. So these are the actual criteria. They share a number of clinical features in having changes in thinking or memory, executive function, planning, organizing, processing, visual spatial function, also other areas that affect sleep, hallucinations, autonomic function, and so forth that you heard about earlier this morning. So just to set the stage on this, this is that one-year rule that was talked about earlier, that we think about Parkinson's disease dementia after someone's had a diagnosis of Parkinson's, typically for a number of years, and then they go on to develop dementia. But when the first or concurrent symptom is the cognitive end or dementia, and then later motor, we talk about dementia with Lewy bodies. And so I'll come back to that in a little bit. So in the current 2023, so talking about our state of the art right now, we have our clinical diagnoses, but we also have what are called biomarkers, or ways that we can have laboratory tests that can help us define and diagnose someone with Lewy body dementia. These are three of those examples. One is a brain scan that looks at levels of uptake in the dopamine system, called a dopamine transporter scan, or sometimes DAT scan. One is a sleep study that's often used to detect changes in REM sleep behavior. So REM is when we dream. We're supposed to be still at night, but people who have REM sleep behavior disorder may be fighting or punching or talking during their sleep, and sleep studies can pick that up. And the other is a heart scan, which is not typically used in the US, but often used in Asia, that shows some abnormalities in both dementia with Lewy bodies and in Parkinson's. So you may hear about some of these indicative biomarkers, again, talking about what's current in 2023, and we'll talk about what comes beyond. I did just want to illustrate, because I mentioned Alzheimer's before, and we talked about Lewy body dementia today, but there are some differences, as well as there are some overlapping features. In this table, which you also have when you get the handouts, illustrates some of what we find common in DLB and PDD, in contrast to Alzheimer's, where in Alzheimer's we rarely see the movement changes, we rarely see the hallucinations, we rarely see that fluctuation of alertness or arousal or lucidity that we can see in Lewy body dementia. But we also see some differences in cognitive symptoms, with more memory and language in Alzheimer's versus the attention, executive function, planning, processing, multitasking, visual spatial function that are characteristic in LBD, and that therapists so nicely talked about in ways to target exercise for dual tasking and combining motor and cognitive. All right. So in terms of 2023 and beyond, we are still fraught with challenges of making the right diagnosis, making it accurately, making it in a timely fashion, and getting people to the right specialist and the right provider early. So I do think this is still a work in process, and I highlight this slide for three reasons. One, because I'm a big Robin Williams fan, lifelong hero, TV movie star of mine. And two, because it's a really well-written article by his widow, Susan Schneider-Williams, talking about his symptoms. And I just pulled these couple symptoms from the first part of the article. And here you can see, actually, many of these are not even neurologic. So yet, adding to how difficult it is for people to get to the right provider quickly, timely, and accurately. So these are all part and parcel of Lewy body dementia. We also heard this morning about the wide variety of symptoms and having that index of suspicion that sometimes these symptoms may be related to Lewy body dementia or LBD. Sometimes they're not, but it's really to think about LBD in a broad, multifactorial way. And all of these symptoms can also interrelate. We know sleep plays a big role in cognition. We know depression can play a role in our motivation or our sleep or how we feel. We know that low blood pressure can also contribute to cognitive changes or fatigue or sleepiness. So they all intersect. And I do want to highlight too that not everyone with LBD will experience the same symptoms or the same timing or the same severity. So, that statement that Sherry said earlier before about you've met one person really has always been true through my career. You've met one person, and each individual has their own journey, their own symptoms, their environment, their genetics, their outlook that they also bring to the table. So I think in 2023, we are still faced with a little bit of this dilemma that hopefully in the future beyond, we will be able to get better diagnoses and earlier identifications. And in my experience, sometimes getting that diagnosis is knowing what door do you go through. Do you see a dementia specialist? Do you see a movement disorder specialist? Are you seeing your sleep doctor, psychiatrist, gastroenterologist? Who is that first entry door that someone goes through in their journey with Lewy body dementia? And I think that's a really critical point, so that people can start connecting those dots and also use this as a way to bring in the team, because it takes a village. So even if you go through one door, if you go through the memory dementia door to get that diagnosis, you may also need to work with a psychiatrist or a sleep specialist or a bladder doctor or a movement disorder neurologist and so forth, so that there are many symptoms and doors to be open. And I think really connecting the dots, so hopefully some of this education will give you the tools to help other providers, help the family, help other people you might meet in the Lewy body world, connect some of those dots and enhance the timing of getting accurate and timely diagnoses. So DLB has often been, the most common dementia people have never heard of. And I hope that in beyond, we at least recognize that it might be top of the list on people's mindset when they go to see a doctor. Oh, all of these things, that adds up to Lewy body dementia. On average, it takes 18 months and 3 doctors to receive a correct diagnosis. I have to say that's been certainly true in aspects of my people have seen multiple specialists, and they haven't quite put everything together to make that diagnosis. But I do think that our awareness of non-motor symptoms has tremendously increased over the years. So, when I started in this field, 20 years ago, there was very, very little out there on dementia and Parkinson's, very little out there in DLB. And now we recognize that these non-motor symptoms are perhaps even to a greater degree than some of the motor symptoms. So there are some efforts that are working on this. I just wanted to highlight a few. So the Diamond Lewy Toolkit, is one of those ways to help push forward our getting improved diagnoses. So this comes out of a group in the United Kingdom, and these are a collection of symptom tools, checklists, awareness that can be used among healthcare professionals, and even coupled with patient visits for screening and looking at this. And they're actually studying this to see, does it improve the diagnosis? Does it help them translate into quality of life care? So in that first slide, I show this continuum of normal aging to mild cognitive impairment to dementia. But in moving the field forward and beyond where we are now, we're really also interested in turning back the clock. So what are the earliest symptoms of LBD? And I'll use the term prodromal, which you might hear, so meaning before someone has the dementia or Parkinsonian motor symptoms. how early can we detect these and how best can we identify them in people? And so this diagram comes from the Parkinson's literature, and it talks about before someone actually gets to see a neurologist or movement disorder specialist because they might have tremor or slowness in their walking, falls, or changes in their gait. That Parkinson's process is pathologically in those brain cells happening years and years and years before, even decades. So if we are going to slow down or prevent these diseases, ideally we want to see how early we can intervene to prevent them or slow down the progression. And some of those early symptoms that can be decades before are nonspecific, so constipation. Okay, that can happen in a lot of people. It has been associated with increased Parkinson's risk, others like depression or anxiety, particularly later in life. And the one that's come about to probably have the strongest indicator is REM sleep behavior disorder, so that acting out of dreams. So we want to look years before for these non-motor symptoms. And a lot of research has been put forth into this area, and I think we are making some headway in understanding these prodromal presentations. There have been research criteria that were published in 2020 for the diagnosis of what was called prodromal dementia with Lewy bodies, recognizing that these symptoms might occur earlier and then have that same kind of end result of DLB or PDD. But these prodromal presentations can take a number of different presentations that I wanted to highlight. So this again is keeping that high index of suspicion for someone who's developed some mild changes in their thinking, may have delirium, which we heard about so nicely from Julie. They might have new onset psychiatric symptoms, depression or anxiety, particularly in an older individual, sleep changes, blood pressure, bowel, bladder changes, reduced sense of smell, which I think COVID has made a little bit tricky on all fronts. But these may be prodromal presentations that may ultimately lead to Lewy body disease. So talking about 2023 and beyond, so how might we predict the development of LBD from these prodromal presentations? And there's quite a bit of research going on in this, either with large-scale registries and studies that are following people with REM sleep behavior disorder over time, looking at biomarkers or imaging or blood or spinal fluid that can have different markers that have been associated with a higher risk of developing Lewy body dementia. And so this is, I think, one of those, what does the future tell us? That we are being able to understand these markers earlier and to be able to follow people over time so we can have the best impact on changing the disease progression. There are also ways that we may be able to improve the diagnostic process. So this diagram comes from the medical literature, not necessarily Lewy body specific, but to me it really highlights that this is a process that involves multiple levels, and we all have the opportunity to intervene and educate on all of them. So here you can see all the way from the patient experience, asking the questions, how do we get someone, if they're starting to have symptoms, to get into the healthcare system for starters? Once they're in the healthcare system, how to find the right people and ask the right questions, or to bring them up from the patient end, to then have a system that includes ways to assess the diagnosis, their accuracy, and even learning from the times that we as providers might not have been accurate about the diagnosis. So I think there are a lot of different ways that we can improve the diagnostic process and get people into treatment earlier and into the right treatments. So what does the future hold on this? So I would like to see that we have greater education and awareness. I think we're getting there in the field. I will say, looking back at 20 years plus of doing this, we have come a long way. When I was sharing with someone at the break, we had no LBD specific materials 20 years ago. There were no pamphlets on cognitive changes in Parkinson's 20 years ago. So we have come a long way, but there's more to go to get people to the right people, the right time. I think there's a role for screening and following people over time who might have some of those early symptoms. I think there's a great role for having improved communication and a team approach. I think you saw some of that already happening today, but bringing in multiple disciplines. And I'll talk a bit more about biomarkers coming up. But I also think the future brings, how do we harness technology? So we have a lot of tools. How do we monitor symptoms in real time? You know, whether it's a smartwatch, Fitbit, you know, some sort of counter that can detect early changes in people's walking speed, their speech, their social interactions, and all those actually may be clues to neurologic conditions. A hot topic in the medical world and medical education world right now is the use of artificial intelligence and ChatGPT. And I actually think can have a role in helping connect some of those dots. You know, say that it's not so far in the future, even, you know, someone clinically putting in all the symptoms into their computer, and hopefully the computer might actually put a readout. You should be thinking about Lewy body dementia. So helping connect those dots and having personalized evaluations, because everyone can be so individual in their journey. So I'm going to switch gears and talk a bit about some of the causes and contributions and biomarkers that are happening in 2023, and I think will take us into the future and beyond. So we heard a little bit this morning about the Lewy pathology, and we know that these Lewy bodies can occur in different parts of the brain. So the brainstem, region called the limbic area, and the region called the cortex area. But we're also learning that people may have different degrees of non-Lewy body pathology or changes, such as Alzheimer's or other changes. We've also learned that there's a loss of neurons in certain brain areas, and this helps us understand why people have certain symptoms. So the brain is divided up into many different regions that communicate amongst each other to, you know, govern our movement, our thinking, our behavior, our autonomic function. And then we've learned that there are changes in brain chemicals. So dopamine's been one brain chemical neurotransmitter talked about this morning, but there are others, including acetylcholine, which is the foundation for some of our medications for cognition, and those involved in mood like serotonin. So our current state of how we think about it uses this as much as the framework. But the story gets more complicated, and I think the future will hold that we need to incorporate all these other elements in neurotransmitters, dopamine and beyond dopamine, Lewy bodies and beyond Lewy bodies, that there's more going on. And some of that involves Alzheimer's or Alzheimer-like pathology and other changes that lead us to think that sometimes when we look at brains under autopsy after someone's donated it after they passed, we see more than just one type of pathology. And why that's important, because a couple things. So the key messages of why all this matters. So different distributions of where this protein or pathology are in the brain influences the type of clinical symptoms and presentations, and perhaps their progression, how fast or how slow. They may also influence clinical trials and therapeutics in how we modify the disease and treat symptoms. Do we need to have therapeutics that target Lewy bodies plus Alzheimer's? Do we need therapeutics that target dopamine plus serotonin plus acetylcholine and so forth? And so I think the future that we will see is one approach needs to be changed into multi-pronged approaches. So we've heard a little bit about biomarkers, but I wanted to take a step and just mention what is a biomarker. So a biomarker really, in essence, is something that we can measure objectively and evaluate. That's an indicator of something that's happening in our body or our brain as a process. So we can measure it by looking at a brain scan. We can measure it with a brainwave test like an EEG. We can measure it in what are called biofluid samples. So that could be anything from saliva to urine to blood or cerebrospinal fluid, also known as CSF, which is the fluid that bathes and surrounds our brain and spinal cord. And these are important ways that we can understand what's happening in Lewy body dementia while someone's still living. And there are ways that we can measure, there are ways that we can perhaps monitor progression. And there are ways that we can also try to understand, is a drug having its target effect by changing some of these proteins or biomarkers? So I'm going to talk about a few that have been really hot in the news lately, and I will try to explain this and make this so it's not super sciencey. So don't worry about some of the details here, but that protein alpha-synuclein that I mentioned earlier, which is the formation when it clumps together of Lewy bodies, can be measured in the cerebrospinal fluid. It can also be measured in the blood, but some of that is not kind of ready yet for prime time in terms of its assays. So there have been a couple papers very recently in 2023 of ways that we can measure synuclein, and including commercial tests that a physician could get a sample of cerebrospinal fluid, send it to the lab to measure the synuclein. And this is done by a process that's called seed assays. So basically, in a nutshell, all this means is you have synuclein that's taken from the blood or spinal fluid. It's mixed with another form of synuclein from the lab, and that leads it to clump together and make more of those clumps that then can be measured under a microscope by showing different sort of fluorescent light patterns. The key message to all of that is this has been a great asset in the field, giving us a tool to measure synuclein, which we know is one of the core elements of Lewy body dementia. It's also been shown in some recent studies that this assay for synuclein can detect or discriminate between those people who have Parkinson's versus those who are what we call, normal healthy controls. It can help differentiate Parkinson's from other atypical Parkinsonian syndrome, something called multiple system atrophy that you might hear about. And then interestingly, in people who have had loss of smell and REM sleep behavior disorder, their spinal fluid is also showing signs of this synuclein on the seed assay. Going back to my point that how do we find that early identification in a way that we can confirm it biologically and then perhaps have interventions at that stage? So you may have heard about some of this in the news recently in the springtime. This is hot off the press. Actually, this came out last week, so I kind of felt compelled to add it in our slide here as another important biomarker in the process of understanding Lewy body dementia, but also identifying preclinical DLB or Parkinson's. So this is something called dopa decarboxylase, otherwise known as DDC, and that's the enzyme that converts levodopa into dopamine. So the dopamine can be used by the brain and body. And so what's so interesting about this is that there are levels in the spinal fluid or blood that detected high levels that distinguish people with LBD from healthy controls and also from Alzheimer's. So remember I said sometimes it's hard to know what door to go in or what diagnosis people get. So this has potential to be used as a biomarker. It also has potential to be used by a blood test rather than a spinal lumbar puncture or spinal tap to access the cerebrospinal fluid. So again, this is for the future. Some of this research is happening now, but it may allow us to have, what I would call a panel of blood tests or spinal fluid tests that we can look at to assess. So, when you go to the doctor and you get your screening, you might get your your kidney function, your liver function, your red blood cell count, hemoglobin. We might have that type of panel for Lewy body dementia with different proteins involved. So that's part of that future. Along in the futures, we're understanding more about the genetics of Lewy body dementia. And I know that's a question I always get with patients and their families or give talks. What's the risk to my family? And I will say most Lewy body dementia to date is not genetic or not inherited or passed along within the family. But there is a small percentage for whom Lewy body dementia does run in families with different inheritance patterns. And so there have been a couple genes that have been linked to LBD, but it's less well understood than in Parkinson's or Alzheimer's. But we're learning about this, and in the future also an area that influences our genes called epigenetics. So that might change how the genes act or function. And we're learning that this may play a role in the types of symptoms or the progressions, or perhaps even therapies or drugs that target certain genes. Also in the current and into the future is we need to understand more about differences that might occur based on someone's race or ethnicity or sex. And these are 3 papers that came out this past year talking about what we know, or really what little we know at present time, but that we need to include these in our understanding. We need a broader representation of the population in our studies and to understand, is it different in different populations? We know there's some sex differences. We know that Lewy body dementia and Parkinson's are a bit more common in men, and Alzheimer's might be a bit more common in women. So why is that? And does that change our therapies and approach as we think about roles of hormones and other differences across genders? All right, so what might the future hold for the causes and contributions of Lewy body dementia? So I really think, one of our key elements when we talk about understanding the biology and taking that information to translate it into therapeutics is we need to know that there's more than meets the eye, even under the microscope, for Lewy body dementia. There's a role for these different pathologies. And if we change one, what happens to the others? So these are questions we need to answer scientifically. We need to understand what are the predictors for developing LBD, what are the risk factors in someone's genes or environment, or based on their race, ethnicity, or sex. I talked a bit about these biomarker panels, which I think are coming, and one of the hopes for the future is we can do these in non-invasive ways. So much easier to get a blood test or even a short scan. So working on that technology is important and coming. And what is the impact they have on diagnosis, clinical trial design, and therapeutics, and ideally prevention? So what kind of changes in lifestyle might we need to make to prevent some of these diseases? And I will make an extra plug for exercises. Exercise is turning out to be one of those neuroprotective ones that, along with, healthy aging might serve us all well. Okay, so I did want to go back to this naming and challenges because I find within Lewy body dementia, this is always such a conundrum and such, almost a disservice, unfortunately, in the field to understand this mix of terminology. So you've seen this umbrella before and the 1-year rule. So this has not only been controversial, I think, among patient communities, but if it's any consolation, it's been controversial among the professionals in the field. So we have argued with each other about this definition. What do we call it? What does it mean if we call something Parkinson's dementia versus dementia with Lewy bodies? Does it matter? Are there differences both clinically and biologically? And so these are 3 papers, one of which I've been involved with, that that highlight there's still controversy even amongst ourselves, and that there are merits to putting them together from a symptom standpoint. There are also merits to understanding there may be some differences between the two sides of the umbrella, with different courses, reactions to medications, and we always debate, should clinical trials involve both groups? Should we be able to split them apart in any way? So if it's any consolation, this is somewhat a hot topic and controversial topic even amongst the specialists. But with that said, talking about 2023 and beyond, our scientific discoveries have expanded tremendously in the past 5 years, past 10 years, and so forth, that there's an evolution of ways to bring these two diagnoses under the umbrella, PDD and DLB, together. And part of that is through the biology, and part of that's through the overlapping of clinical symptoms that I talked about. So you may hear about some of this. It's been in the news quite a bit this past spring, that there's work in process or progress to propose defining LBD from a biologic standpoint. Now, this is probably more important from a research standpoint at current times than a clinical going to see the doctor and getting the diagnosis, but it helps harmonize our understanding of the different proteins that I mentioned, the different biomarker assays, and how we might be able to diagnose people earlier and identify those at risk. So they're not yet published, not ready for prime time, but the research is trying to unify this concept of one biology that drives the presentation of Lewy body dementia. And I think one thing that we wrestle with is there one contributor that leads to multiple presentations? Or is there a single presentation that's really caused by multiple biologies? And I think I've shown some evidence for both sides, but also that there are multiple biologies involved. This work's not unique to the Lewy body community. So the Alzheimer's field is also undergoing their kind of same revolution or evolution based on scientific discoveries and our understanding of these biomarkers. So there's been also a proposed research framework to think about Alzheimer's based on its biomarkers and biology as something that happens even before someone has those clinical symptoms. So this is a way to diagnose people earlier by these biomarkers, even before they might have symptoms, knowing that they might be on that trajectory and looking at what sorts of therapies or interventions could come at play. So I think that the key messages and the take-home messages from those definitions and biological definitions, are several. So one is remembering that not all dementia is Alzheimer's. So I think speaking to the chorus here of the importance of Lewy body dementia and recognizing that it is different from Alzheimer's, the importance of early identification and intervention, and really the future leading its way to prevention trials and therapies that not only improve the symptoms, but what we call modify the disease itself or slow it down. So if I had a wish list too, I think my future would also include greater clarity for our naming, not only for our patient communities, but also our healthcare professionals. And hopefully we will be able to at least come up on the same page and to instill that it's okay to ask questions, to providers to understand, well, if I read this terminology, what does it mean? Or I saw in my chart, it said PDD or DLB or MCI, what does that mean? Or why does it seem like my diagnosis changed? So that's something I think that we hear often. The future is really bringing these biomarkers into our research definitions and clinical trials. So with that, I want to turn and talk a little bit about what's new in clinical trials. Our current symptom management is very much what we call a symptom-based approach. So what is bothering the person with LBD or their care partner kind of the most at that time, or perhaps causing safety issues, So as a clinician, we sort of think, well, where do we need to go now? What do we need to do from a medication or therapeutic standpoint? And often it's helpful to address these in different buckets, thinking, what are the motor symptoms? What are the cognitive changes, neuropsychiatric or behavioral changes, sleep, autonomic, that blood pressure, bowel and bladder function, or sensory, things even like vision or pain or smell. Our current management is really focused on, a number of these things, often in isolation. So medications, you heard about several this morning from Dr. Merman. Non-pharmacologic therapies like exercise, mindfulness, stress reduction, nutrition, lifestyle changes, rehabilitation. So my shout out to our PT, OT, and speech out there, and exercise wellness professionals, but also psychosocial. So the great importance of our social workers, counselors, psychologists, psychiatrists, and mental health professionals, and of course, research. And I think really the future, we need to be able to bring all this together. So it's not just medications, it's medications plus non-pharmacologic, or it might be exercise if someone's very early in the stages of their disease, and then adding medicine. So there's a lot of art to this, but I think the future needs to have all of these incorporated. And I will also make a plug that, knowing that you've heard about some of these therapies, some of the medicines, it's okay to bring them up and say, okay, do I need speech therapy? They've never mentioned it. Should I bring this up at my next visit to be proactive or screen for swallowing issues or cognitive changes? So hopefully these give you more tools in your toolbox. So I mentioned before that in my off-label medication disclosure, there aren't that many medications that have been specifically approved by the FDA for LBD, for DLB or PDD, but there are a few. So motor medicines, we talked about levodopa this morning, approved for motor symptoms, rivastigmine for dementia, and pimavanserin for psychosis, those hallucinations and delusions. That doesn't mean that we always need an FDA-specific LBD medicine, because we also have some really great medicines that have been used in the general population, or antidepressants, or some of our medicines for constipation, or so forth. But it is helpful for us from a research standpoint to know how they are used and processed in people living with Lewy body dementia. So this is kind of the current 2023 state of the art. What is currently happening, I actually think is quite exciting. So this is just a screenshot of clinical trials that are happening now for Lewy body dementia. So I basically just put in the search term Lewy body dementia in clinicaltrials.gov and got a list of 178 studies that are happening worldwide. And there are, of those, I think 64 that are actively recruiting participants. So they're not all here in Omaha. There are some in different countries or different parts of the US. But if you're not familiar with clinicaltrials.gov, it is a fabulous resource to find clinical trials on really any condition. So you can put in any disease name, any symptom, and out will pop a list of that. So I do think that's really exciting that we have quite a bit going on, including some of the ones that you mentioned that you're doing right here, right now in Nebraska. So what's been interesting in the clinical trial pipeline is that there's been a great growth in the types of trials, the stage of the trials, and the type of symptoms that are being targeted. So we need more effective and safe medicines, not only for the cognitive or dementia symptoms, but also for REM sleep behavior disorder, mood changes, cognitive fluctuations. So trying to understand that is a really big piece of hopefully what the future will bring. Why arousal and attention can go up and down, or day to day, or week to week. Looking at fatigue and having therapies that address all of these. there's work being done to address what we call disease modification. So slowing down the Lewy body dementia, maybe impacting the formation of the Lewy bodies or the synuclein. And some of these are targeting different aspects of the biological system related to things we call oxidative stress, things we call growth factors or neuroplasticity, inflammation, metabolism, and other things that are really exciting in the science field that lead to new medications. So you'll see some of these have names you might have heard of. Some of them are names that you would not have heard of because they're novel agents. Also in the clinical trial pipeline, there's a big push to look at what we call repurposing of drugs. So drugs that are already approved for one indication that then have gone on for further study, and we've learned that they might actually have implications or interactions in the brain. And so this might be something that was approved for, one example is something that was approved as a cough suppressant medicine that is now being studied for dementia with Lewy bodies because of an particular enzyme it works on that's related to one of those gene mutations, GBA, that I listed earlier. There's another medicine that's actually a prostate medicine that greater understanding of its mechanism suggests it may actually have an impact on neurologic conditions. So some of this repurposing can be helpful. It might actually, because we have safety data and clinical trial data in another condition, help accelerate the timeline from drug development to approval, which many of you may know is, often more than a decade by the time something's in a chemistry lab to the trials to FDA approval. And so some of these trials look at what we call phase 1, 2, and 3. So phase 1 mainly looking at safety, phase 2 mainly looking at does it have an effect? Does it start to show a clinical signal? In phase 3, thinking about is it effective and safe, but also might it compare to a placebo or a sugar pill that demonstrates that clinical benefit? So I will have to say that I am actually really excited and pleased to see this growth in clinical trials over the years. And it's always nice when you see it mapped out like that in a graph. So I do think there's a lot of hope and excitement on the horizon. So way back when I started my career is at the very beginning of the 2002, when I was a fellow all the way to current, and just the sheer number of trials. There were times that we really didn't have many trials to offer people. And now when you go online, there are a whole variety of medication studies. There's studies looking at interventions like exercise or diet, studies looking at, REM sleep behavior disorder. So I think the future brings this continued growth and interest from stakeholders, interest from pharmaceutical companies, interest from device companies and tracking that will only serve our LBD community well. So one of the aspects to conducting clinical research is also trying to understand the needs and priorities of people living with Lewy body. And so this is a study that was done by a group of us associated with the LBDA, looking at a survey that was online of over 800 people completed it, with 131 people living with Lewy body dementia and 832 being caregivers of people with LBD. And if you just look, I know it's very small, as I'm going to read it here, that, the top, 70% or so of people wanted to understand medications. They wanted to understand more about what's going on in the brain in terms of Lewy body, learning more about trying to look at the diagnosis and have new medications. And so I think that's an interesting insight as to where we should be focusing some of our efforts to serve the needs of our community. There's also been really promising and hot this year is work in Alzheimer's, leading to FDA approval of a drug called lecanemab. And so this is not Lewy body dementia work, but it may have implications for LBD. So these are studies looking at drugs that target amyloid as a protein. So we're kind of looking at drugs that now that also target synuclein as a protein, but knowing that some people with Lewy body dementia have amyloid or Alzheimer's pathology, this begs the question, I don't have any answers or insights on this. Will these Alzheimer's drugs also play a role in treating Lewy body dementia? And I think that is a wide open question, but the fact that this research has come to the fruition in the Alzheimer's field led to FDA approval of a medication that has shown some degree of slowing on the clinical scales and changes in the proteins that are measured in the spinal fluid. It really raises the question, what is the future for LBD? Even if it's not necessarily these drugs, what is it that we learn from this experience of conducting these trials and take that into our field of LBD, because it will only make us smarter and better. All right, so just to summarize that section, I think the future from the clinical trials end, we need both symptomatic therapies to treat the cognition, treat the behavior, motor, and so forth, but we also need ways to slow down the disease. And using some of these biomarkers and what we're learning from the Alzheimer's field, I think will help pave that way forward. We know that there are multiple types of therapies, and again, just a plug to make sure when you are having treatment for LBD that your regimen might include or should include even some degree of medication and non-medication therapies. So I think we will live in a world where there are not only multiple types of therapies, but perhaps cocktails of therapies. So a variety of different drugs to treat different symptoms, and perhaps different drugs that treat different biological pathologies like synuclein, amyloid, and others. All right, so just to close, I wanted to mention some of what's going on in advocacy, because this takes a village. It takes a village of healthcare providers and people like you here in the audience, but it takes a village globally. And so over the past, really, decade, we've seen a wide initiation of research in all areas of the world. So here you can see groups in the United States, other areas of North America, a variety of countries in Europe, Australia, China, South America, that are conducting research in Lewy body dementia. Some of that might be trials or registries or collecting samples or data, but really what this has led is us as researchers to be able to work together and collaborate across the globe. And I think there's strength in numbers. We can do far more together and far more without always reinventing the wheel, but learning from each other. And I think that is, something that has come about in, really the past 5-10 years, and it's very, very exciting on the research end. Similarly, there's a global community. So, another message is you are not alone. You are never alone in this. We heard about great resources from the LBDA, and I've had the pleasure of working with them for more than a decade. But no matter where you are in the world, there are other Lewy body groups. I think silver lining of the pandemic has broken down some of these barriers. You can communicate and Zoom with other LBD groups or support groups throughout the world. So really this is a collective effort, and I think that offers a lot of hope and excitement. The other is that there's been a growing trend, and I think a very important one, of engagement and participation. So I think the first step is coming here for education, spending your whole day with us to learn more about the health conditions, learn more about research, learn more about treatments, become engaged. So there's more motivation to be more knowledgeable and really more empowered. So to have that ability and motivation to have confidence and understanding about the disease, about healthcare choices. And really, we think about this as being much more person-centered and advocating for shared decision-making. So having a dialogue with your healthcare provider team, with your physician and staff to help make those decisions, even sometimes to make those decisions together about treatment options. So I think the future could bring more of this, of having people with lived experience having a role as stakeholders, not only in the clinical, but also even the research process, being part of the clinical trial design and helping understand what we need to know and how we can do it better. So in order to further science too, we need people's participation. So always a plug that there are many ways to participate in research, from clinical trials to filling out surveys to having your blood drawn or brain scanned and all sorts of things. So there's a lot of value in that. And again, it takes a village. And there are now studies that show that incorporating people with what we call lived experience leads to better health outcomes, leads to better well-being, better quality of life, better cost effectiveness and decreased use of healthcare or hospitalizations, and greater confidence. So just a plug for that. There's also literature. This is a study. I just like the diagram that shows that really this is a continuum and a flow. And really part of that question is, what do we need to learn from you? And what can we share with you? And what, this is a give and take of a learning process. So that will help us advance the field and our therapies. So I think from the future on that standpoint, we are already initiating global education and awareness and global research. So I think being able to pool those resources, pool that knowledge, help us understand LBD across different populations. Is it different in Asia from in North America? Is it different for men and women, as I mentioned before? And include the valuable experience of all of you with lived experience, whether from a patient side or a care partner or family member, and improving our ability to communicate and have engagement and empowerment. So I do think these will also have effects too on outcomes and quality of life, and really getting us to a cure and better treatments faster. So with that, I just had a few concluding thoughts here, just to summarize that, over the past couple of decades, we have had greater recognition of LBD. So having LBD, as an organization too, among the forefront, among Parkinson's and Alzheimer's organizations, and greater recognition of symptoms and education. But I do think we can do more. And, the tools that came out today as education can be helpful to educate providers, anywhere in your journey, people in the community, people in the stores, people to understand why it might take longer or what they need to know about Lewy body dementia. So I think that's really important. And also getting, more timely diagnoses and treatments to get people to be proactive and to the right provider early on. But these are really exciting times. I think neuroscience is just blossoming with a lot of scientific discovery and understanding how to take that path from discovery, translating it into people's hands. And that's not only with drugs, there are biomarkers, there's technology and digital biomarkers of how we can track and measure things. And I think that will all play a big role in our clinical trials and therapies. So lastly, one recurring theme is it takes a village and ample opportunity to engage. Happy to take any questions and look forward to engaging with you all in the future. And congratulations on your initiative. Thank you.
So I think we're going to go ahead. I'm going to make some closing remarks. Dr. Goldman, Dr. Merman, myself, our wonderful therapy group, Dr. Fargo, we'll hang around here and you guys can ask questions. Also, in your booklets, there is an evaluation form that we would really appreciate if you would fill this out. And in addition, on the back of that form or on the little tablets that are on your tables, you can also write out questions and we will address those in the upcoming issues of the Lewy Body Dementia newsletter. The first one came out and there'll be another one coming out in November, December. So all of your questions, we will get them to the appropriate person and they will be in the next issue of our newsletter. Also, people who are on the webinar on via Zoom, they will have a pop-up for their evaluation conference when you leave the webinar that you can also evaluate the program. So please do that. We want to, this is the inaugural one, but we're going to continue them annually and just to make them better and to provide information that's useful to you. I want to take a few minutes to thank so many people for making this day possible. Thank you to our entire movement disorders team, Don Franklin, the Lewy Body Dementia Program Nurse Care Coordinator, our entire Department of Neurological Sciences, all our speakers, Heartland Neurological Therapy and Wellness, Lewy Body Dementia Association, and Dr. Jennifer Goldman for providing us with her expertise. It was absolutely wonderful. Also, a very important thank you to Sally Weather. She is our absolutely amazing web, social media, and events coordinator, and this girl works her tail off. She does not get enough praise with her job. It's just kind of expected, but she really does. We're texting in the evenings sometimes or emailing, and we're never really off the clock when it comes conference time, are we, Sally? So had the pleasure of working with Sally for 2 or 3 years now, and she does an absolute fabulous job. So thank you. Also, we had an extremely efficient administrative project associate that helped us with lining everything up, Becky and Bella, and we had to change in our administrative associate personnel while we were planning this conference, which made it a little bit difficult. But Dr. Goldman got here, her flights are made, her room reservations and everything. So I mean, everything worked out. And it honestly was between three people of getting her here. So that was absolutely wonderful. I've had several people ask me about the initiative. So they want to know how they can help, how they can donate. So I did have our NU Foundation bring us some cards down. These are on the front of the table. And this is the Lewy Body Dementia Initiative Funds. Anything that is donated to this fund for memorials, for other donations, for whatever, stays with the Lewy Body Dementia Initiative Fund that has already been started by our generous donors. So they have, a lot of times donors don't allow funds to be added to their established funds. However, due to the donor being anonymous, they were absolutely very supportive of anybody who wants to be able to donate to our fund. So the funding pays for our Lewy Body Dementia Clinic. It pays for the conference today. It pays for the newsletters. It pays for our support groups. It pays for any activities related to the Lewy Body Dementia Program. And I do want to thank, there's several of you in here that have already donated. Thank you very, very much. Most importantly, thanks to each of you for attending our Lewy Body Dementia Initiative inaugural conference, either Zoom or in person. We were so privileged and so happy to have you here. You are all part of history. History was made today. As Martin Luther King said, we may have all come on different ships, but we're in the same boat now. Thank you.